We are going live in 3, 2, 1. We are live now.
Good evening, everyone, and welcome to Symbiosis Series Webinar 4, brought to you by Foxy Imaging Science Committee in association with the Bhopal OBGY Society and the Bhopal Menopause Society. And today's topic is Obstetrics Ultrasound Made Easy. At the start, I would like to welcome Dr. Monica Singh. Just a second, is a technical glitch.
Good evening, Manisha. Hello, Purnima.
Ma'am, good evening. Very good evening.
Madam, these are my program coordinators, my MOCs, both very hardworking girls. Any problem, Vivek?
Yes, ma'am, all good now. Sorry for this technical glitch. Now I would like to introduce Dr. Monica Singh, who is the Honorary Secretary of MP Chapter ISAR and is also the convener for Symbiosis Series. She is the Vice President, Bhopal Obstetrics and Gynecology Society, Vice President, Bhopal Menopause Society, Organizing Secretary, 27th Annual ISAR Conference 2023 Bhopal. She has been the co-convener for ISAR Perfection Series and founder and convener for Foxy Symbiosis Webinar Series. Very warm welcome, ma'am, and over to you.
Thank you so much, Dr. Vishal, for the introduction. And without wasting any further time, because we've got dignitaries with us, let us start Symbiosis Webinar 4 with Foxy Imaging Science Committee, for which I have to be very thankful to Bela Bhatt ma'am. Because of her affirmation, we could do this program. And I'm always indebted to my chief guest and my guests of honor who go out of the way to support us and to be with us. At the outset, I would like to thank our President, Foxy, Dr. Rishikesh Pai sir, Dr. Madhuri Patel ma'am, Secretary General Foxy, Vice President, Dr. Gitendra Sharma, and Chairperson, Imaging Science Committee, Foxy, Dr. Bela Bhatt, for holding the flag high of Foxy and supporting us in this program. I think we just give our thanks to Dr. Pai, who is always with us in any activity we do in Foxy, even in the smallest cities, in the smallest societies. Sir's support is always with us. He is the most distinguished illuminary in the map of Foxy in India. You can advance the slide, Vivek. Yeah. Coming to Dr. Madhuri Patel ma'am, she is Secretary General Foxy. And again, I must confess that when I did the first time Symbiosis with Perinatology Committee and Dr. Chinmay Rath, madam had joined. If any of you were there, I think my girls were there. Madam joined for an entire half an hour or 40 minutes, and she gave us a very nice talk, and she supports all these activities wholeheartedly. A very humble and sweet person, as you all must be knowing. And because of her, we hold our head high. Welcome, madam. Dr. Gitendra Sharma sir is our Vice President Foxy. He is practicing in Ahmedabad. He is a very great medical legal counselor with a gold medalist during LLB, author of several medical legal books, a great orator, has given so many lectures, and he is the Vice President Foxy 22 to 23. We'll have the pleasure of having him in MP in January. Now I have the extreme pleasure of welcoming and giving thanks to Dr. Bela Bhatt Madam, Chairperson Foxy Imaging Science Committee 21 to 25. Madam is the lead consultant of Dr. Bela's Women's Hospital and Fetal Medicine Center, Mumbai, and the fetal medicine consultant at Babasaheb Ambedkar Memorial Central Railway Hospital, Mumbai. She is FMF UK certified sonologist for fetal abnormalities and for nuchal scan. Madam is not only the life member of SFM, but also holding the post of Joint Secretary AFG Mumbai, Managing Council member ISPAT, and the recipient of several prizes. She has got the CS Don First Prize at AICOG Bhubaneswar. First prize of Foxy has talent. Madam is a very great artist. Anybody who is into fine arts knows Bela ma'am. I think that is a separate side of her personality, which sometimes we don't know whether to take the academic part higher or the artistic part higher. But I think they stand in perfect balance. So we have witnessed her recently doing great shows. She was there in Femtech 4, where she was the judge and the performer in a great, artistic event. And she has also been the national convener for Foxy Superstar Competition, national talent coordinator for Foxy Has Talent. And most importantly, because of Dr. Bhatt sir, because of Hitesh Bhatt sir, madam has the confidence and the courage to, fight her cases in person. She has won PCPNDT cases in Bombay High Court by fighting in person. We congratulate you, ma'am, and we are truly impressed by your CV and your personality and your, skills. From Bhopal Ops Gynae Society, we have Dr. Anita Srivastav, ma'am, and Dr. Shabana Sultan. I think they'll be joining us. President, Secretary of our society, very dynamic ladies, always into every activity we conduct in our society and out of it. From Menopause Society, we have Dr. Shashi Srivastav and Dr. Shraddha Agarwal. Again, their support is like always with Bhopal Ops Gynae Society. Both the societies in our city, they work in unison, and sometimes all the programs are also merged. So we have very big gala events because of them. I think before going to our chief guest and guests of honor, Bela ma'am, would you like to address us?
Sure. Thank you so much, Dr. Monica Singh, for kind words of introduction. But I would like to tell you that you have been doing fantastic academic work that we have all been witnessing since quite few months. And congratulations for the same. And it's my pleasure and honor to be part of this wonderful webinar, the series of Foxy Symbiosis webinars. So first of all, congratulations.
Thank you,
And I would like to extend a warm welcome to all the dignitaries and all the delegates on behalf of Imaging Science Committee, Foxy. And we all know Dr. Rishikesh Pai sir, President, and Madhuri Patel, Secretary General, and Dr. Gitendra Sharma as the VP in charge, all have been supporting these academic activities. So extremely thankful to all the Foxy office bearers to, support us to keep doing this good work in Foxy. And of course, my namaskar and welcome to our chief guest and guest of honor, Dr. Archana Basir ma'am, who's the VP, past VP, and also past chairperson Foxy Imaging Science Committee. And we have been walking on her footsteps and try and continue doing the same good work. And also dear friends, Dr. Varsha Baste, Dr. Komal Chavan. So welcome on behalf of Foxy Imaging Science Committee and also Bhopalogy Society. I'm extremely thankful to the President Secretary of Bhopalogy Society, Dr. Anita, Dr. Shraddha, as well as Dr. Shashi and Dr. Shraddha from Bhopal Menopause Society. So thank you very much for having me here. Thank you.
Thank you so much, Bela ma'am. And now I invite my chief guest for the evening. Dr. Archana Basir is star of Madhya Pradesh. She belongs to the city of Indore, but she has taken Indore and MP to the national map because not only has she been the Vice President Foxy 2020, but also the organizing secretary of AICOG 2021 in Indore, which was a huge success despite the delays of COVID. She is fellow representative AICC RCOG West Zone. She has been the past chair of Imaging Science Committee of Foxy, a chair of CEFOG, and madam is the Guinness World Record holder for removing the largest uterine tumor. Past positions, she has held the stellar positions of Foxy Imaging Science Committee, CEFOG also, Organizing Secretary ISAR 2016, and she is the Managing Committee member of prestigious bodies like ISAR, IAGE, and ICOG. Welcome, Dr. Archana Basir, and we would like to have a few words from Madam.
Hi, good afternoon, everyone. At the outset, let me thank our very meticulous, punctual Dr. Monica Singh for inviting me, honoring me with this position of chief guest in Symbiosis. I think Symbiosis is perfect word for when she has united Bhopal Ops Gynae Society, Menopause Society, and Foxy Imaging Science Committee. So congratulations to you, Monica. Congratulations for bringing galaxy of stars. You have handpicked your speakers in form of Bela Bhatt, Smita Dige, and Dr. I'll just not remember the name,
Yeah,
but
Priya
there's
Deshpande.
another speaker.
Priya
Yeah,
Deshpande.
and you have really handpicked your, guest of honors is who are the upcoming vice presidents of Foxy, Dr. Varsha Baste and Dr. Komal Chauhan. And I think it is going to be a really a phenomenal webinar, because you have included all the societies, tried to include all the societies of Madhya Pradesh, Chhattisgarh, and I think it's been in the air that this symbiosis webinar is happening. So I think all the delegates and who are going to be joining this webinar are going to get benefited by this very basic topic of learning the ultrasound, obstetric ultrasound, because I think all these three speakers are going to be bringing you the points like how to predict the problems, how to prevent and act in time to save the mother's life. I think that is the very important topic you have chosen. So I am really happy that I'm part of it, and I'm just going to be listening to these speakers. And you have a very interesting panel also upcoming, which you and I think Dr. Anshu are moderating with good panelists. And it is very important to learn on a case-based scenario how to really identify the problems and help the women. So congratulations, thank you, and all the best for wonderful webinar, Monica, Manisha, and all the team of Bhopal Gynae Society, Bhopal Menopause Society, and Foxy Imaging Science Committee. Bella has been doing great work. I think she has done a tremendous work in her tenure, and there are many more things from her to come. And congratulations to Dr. Pai and Dr. Madhuri Patel for a very successful tenure as President and Secretary, and Dr. Geetendra as well. Thank you so much.
Thank you so much, ma'am. Your blessings mean a lot to us, and your words have been like nectar, I mean, it's so nice to hear you. You have touched every point of the webinar, all the people who are involved. And trust me, when I involve my friends like Dr. Varsha, and, when I call you, I don't even hesitate 1 second. I mean, these people, they feel, how do I make the program in 2 days? But it's like, it's not, I don't plan anything. I'm very spontaneous person. I just feel कि ये अच्छा लगेगा यहाँ पे आएंगे. And I'll just let me give a call. And I'm so confident they'll say yes. I don't know, that vibes are there. I feel no, madam will say yes. So thank you, Archana ma'am. And I now invite my guests of honor, Dr. Varsha Baste. I can't tell you how much influence she has had over not only many gynecologists, but especially over me, because she is a beautiful person inside out. She has taught us about beauty of life. Like, despite being a gynecologist, despite running a hospital, doing IVF and doing obstetrics practice, you can still appreciate beauty of small things of life. She is a Raj Yogi. She has involved me in Raj Yoga. She has taught me about Brahma Muhurt, about sleeping early, getting up early, which I still have to follow. But I'm truly your admirer, Dr. Varsha. And just to introduce her a little bit, she is a practicing gynecologist of infertility specialist of Nashik, and she is recently won the elections for Foxy Vice President West Zone. And we congratulate you, Dr. Varsha, because you will be taking up the prime position of Foxy, and soon we would like to see you even as president. And she has been credited with Fort ICSI and PGD Baby of North Maharashtra. She has held prestigious posts in Nashik OBGY Society of President. She has been the chairperson of Foxy International Academic Exchange Committee. She is the recipient of prestigious Dr. Anandibai Joshi Award, Amox B for Stree Puraskar by Governor of Maharashtra, Foxy Champions of Foxy Award, Foxy Excellence Award for Outgoing Foxy Chairperson. She is the able organizer of several national and international conferences, participant as well, founder member of MSR, Maharashtra ISAR, life member of IAG, FICOG, and has a diploma in infertility from Germany. Welcome, Dr. Varsha. We would like to have a few words from you.
Thank you so much, my dearest Monica, darling, and Bella Kepul. I can see all my dear friends scattered all over here, and I am really so happy you have that knack, Monica, to choose the best and deliver the best and present it in such a elaborate manner. You really, my heart went flutter, because when you edify so much to everybody that we get really elated. Thank you for having me here, and I am really delighted. I saw the program. What a wonderful program, and what not, Dr. Bela. But I really admire her work and her enthusiasm and multitasking personality, and so vivacious she is. And with the help of her, you have organized 3 topics, panel discussions, fantastic topic, the color Doppler in basic, then in preeclampsia and second trimester, and the panel also case-based panel by Dr. Basir and Anchu Basir and whatnot. I have really feel second home for my Bhopal. Both those Srivastavas, Shashi and Anita, and all this. They are really wonderful. I have experienced their hospitality. We had organized Rajog, very big event by Shashi and all Rajog, all Bhopal units, Bhopal Obijay Society and all over India. Many had contributed and attended that event. Thank you, Dr. Archana Basan, madam. After long, I am seeing you, and your daughter is also there. So the legacy is going on of ultrasonography, I think, after Archana Basir, Bela Bhatt, and Dr. Anshu Basir also is there. I can see Shruti Malvi and many my friends over here, and I'm really feeling so nice. It's really pleasant to have good vibes, and you are giving me that feeling again and again. Thank you, Dr. Monica. And I really wish all the success for this wonderful webinar. The program is good, the speakers are excellent, and the atmosphere is good. And Bhopal OBGY, everything वो मस्त conclusion बन के आया है. So all the Foxians will be delighted to attend in and get many take home messages for sure. Thank you for having me here. God bless, and I wish you all success in your endeavor for ISAR and for Foxy chairpersonship also. Thank you, Monica, darling.
Thank you so much, Varsha. I think nobody calls me darling except you, not even my husband.
रणदीप रणदीप तो काम में इतना भूल गया है बेचारे. And I really like your family also. दोनों बच्चे भी कितना मस्त है. I really admire and I always look forward to watching them growing and achieving such a success. And even Randir also is such a hyper dynamic person. Thank you so much.
Thank you so much, Varsha. It's beautiful having you here. And now I have the pleasure of introducing another one of my very, I won't call her my friend. She's senior to me and she's such an accomplished person. Both Varsha and Dr. Komal, they were sailing in the same ship. And in fact, Dr. Sneha is also very close to me. So out of the 3 people contesting for West Zone Vice President, I really didn't know that who will win, but see, the best wins. And I hope Dr. Sneha wins next time. But Dr. Komal, she is like a star. People say that Mumbai people have an advantage, but Mumbai people work very hard. What they do is from pure hard work. So, madam, we congratulate you for being the Vice President-elect Foxy 2025, Zonal Coordinator for Foxy President 22-23, Core Committee VAD Cell Foxy, Governing Council Member of ICOG, Chairperson of AMOG's Family Welfare and MTP Committee, Chairperson of Foxy Medical Disorders and Pregnancy Committee, Member of Managing Council of MOGS, Scientific Secretary AFG, Joint Secretary ISUPA Mumbai, and National Expert in several Foxy projects. We have seen her in the editorial board of several journals. We have seen her, her students got so many prizes and awards. She's a DNB teacher. And I literally saw every second recipient of prize in Femtech was Madam's student. And she's honorary professor, Dr. R.N. Cooper Hospital and HBT Medical College. We welcome you, ma'am. And it's a pleasure to have you as chief guest in Symbiosis. Dr. Komal is there?
I think she had some meeting of emergency, so she said she'll be
So whenever she joins, Manisha, let me know. Madam will speak a few words. And now I would like to have a few words of encouragement from my president, Dr. Anita Srivastav, she is there, and President Bhopal Menopause Society, Dr. Shashi Srivastav. Can we have the CV, Dr. Vivek? Yeah. Dr. Shashi Srivastav is President Bhopal Menopause Society, a very senior gynecologist of Bhopal, and she is not like a president. She is like family. In the morning, I called her, Madam, mera exam ka roll number nahi aaya. So, that sort of a thing. We feel that connect with her. She said, Monica, whatever you're doing, you have to give the CIMP exam. Now, because of her, I have to study that whole book of menopause. So she encourages. She tells you to go ahead. She says, don't stop, go ahead. She has a kind word for everyone. She has such a big heart. She gives so much. She keeps giving. So, madam, I love you. And please, we would like to have a few words from you. Shashi ma'am, you have to unmute.
I must say, Symbiosis is one of the unique kind of webinar which is conducted by the Monica with a good vision. And this time, always there is a good topics there. And this time the ultrasound, which is I think is stethoscope of the each gynecologist. So it is really wonderful. And she collected the galaxy of stars over here. So I feel this is the one of the most informative and wonderful webinar should be going on. So welcome all of you, and thank you for the kind words. I am not that much capable of doing something, but you should go a long way ahead.
Thank you. Thank you so much, Shashi ma'am. I really appreciate your presence. We are blessed. Is Dr. Anita there? Dr. Manisha? Dr. Anita?
Yes, logged in now. Yeah, she logged in. Yeah.
Okay. I think
yeah, she's there.
Hello.
Okay.
Hello. I'm
Hello.
there.
Yes. Anita Didi, can you please say a few words for our webinar from OT? Have you delivered the baby?
Monica, I'll just say, you are one of the best person to organize such a thing with such a zeal and enthusiasm. You are doing right and left everything you want, and you can achieve whatever you want. And side by side, you are teaching the youngsters very well. I saw you teaching sonography last 10 days back on 9th and 10th of December at Chirayu. And you are awesome. All your students appreciated you so much. It's a pleasure having you with me as my vice president, and I'll wish you all the good luck.
Thank you so much,
Thank
Anita.
you.
It means a lot that you have joined from OT, God bless you. God bless you. And we are blessed to have such a sweet president like you. So I think Bhopal is all, honey and sugar and sweetness and everything. So moving on to my program coordinators. I have been very, very comfortable with these webinars. You must be wondering how Monica is doing this. This is because of my left and my right arms. Dr. Manisha and Dr. Purnima. Dr. Manisha Jain is a very dear friend. She's treasurer of Bhopal Obs Gynae Society. She's the executive member of MPAGOI, organizing member MPOX Bhopal, and also a part of the conference of ISAR Bhopal, life member of various societies, a distinguished faculty in national and state conferences. She is working as professor OBGY in People's Medical College and Research Center. She is an avid publisher in various journals, a best paper awardee at MOG's OBS NCD conference, and has a teaching experience of more than 15 years. Next, I invite Dr. Purnima Tiwari. Dr. Purnima Tiwari has moved to our city from Nagpur, so we are very lucky to have her. At present, she is working as ART consultant in Apollo Sage Hospital, Bhopal. She is an alumnus of prestigious Maulana Azad Medical College, Delhi, and has been bestowed with several fellowships and awards. She's a very active member of Bhopal Obs Gynae Society, and along with me, she is program coordinator for not only Symbiosis Series, but also ISAR Perfection Series. Welcome, Purnima. Now I hand over the program to both my MOCs to take it ahead. Thank you so much. Dr. Purnima, are you there?
Ma'am, Dr. Manisha, ma'am, I think she's having some network issues, so I'll take the session.
Please go ahead. Yeah.
So for our next session, I would Dr. Monica Singh, ma'am, she is the convener of our Foxy Symbiosis Series, and Dr. Randir Singh, sir, is co-convener of Foxy Symbiosis Series.
I think you can
Next
go to
slide.
session. You can go to the first
Dr.
session. Yeah. Just move to the first session. Yeah.
Okay, thank you, ma'am. So for our next session, I would like to invite our chairpersons.
One
Our
sec,
chairpersons
one
is
sec.
our Dr. Shruti Malvi,
Sorry,
ma'am.
Purnima. Manisha, your network is back?
Yeah, I'm back.
Is your network okay?
Yes, ma'am is back.
Yeah, please carry on, Dr. Manisha. Please carry on.
Yeah, just to begin with our most awaited academic program. Thank you so much, Monica ma'am. With the blessings of all the dignitaries present here, we start the academic session. And for the first session, we have with us Dr. Smita Dengle, who will be talking on the prediction of preeclampsia. Dr. Smita Dengle is from Bhopal, and to chair the session, we have Dr. Shruti Malvi from Hoshangabad and Dr. Tabassum Dala Madam from Raipur, who will be chairing the session today. Dr. Shruti Malvi ma'am is the director of the Malvi Hospital at Narmadapuram, and she's the founder secretary also of the Narmadapuram Hopkins Society. And currently she's working as a president of the Narmadapuram Hopkins Society. I welcome you, ma'am. Have you joined, ma'am?
Yeah. Yes.
And the next chairperson we have Dr. Tabassum Dala Madam from Raipur. She is the president of the Raipur Hopkins Society and the vice president of the IMA Raipur. She has done diploma in minimal research surgery and ART, and she's working as the director of the Javesa Hospital Raipur. She has her Foxy recognized ultrasound training center to her credit, and she has been organizing chairperson and secretary of the various conferences to her credit. I welcome you, ma'am. Over to chairpersons.
Thank you so much. At the outset, I would like to thank the organizers for inviting Raipur Society, and our members are also here, and choosing such nice topics. And the speaker today, please welcome Dr. Smita Dengle. Madam, she is going to speak on prediction of preeclampsia, a very important topic because preeclampsia has been troubling us all from the day we joined our BG courses. So here I request Dr. Smita ma'am to kindly speak on the topic, and she is a fetal medicine specialist, Bansal Hospital, Bhopal. She is FUK certified for NT-scan and OMT-scan. She is FMF certified for invasive procedures, Foxy certified trainer for ultrasound in obstetrics. She is faculty fetal and gynec imaging. She is member of ISOG and life member of Society of Fetal Medicine, executive member MP chapter SFM, member of Foxy Imaging Science Committee, faculty at state and national conferences, and she has got special interest in academics and training, fetal screening, fetal interventions. So welcome, madam.
Thank you so much. Thank you, Tabassum, for the kind introduction. I'm so glad to be a part of this symbiosis. And let me straight away get to the lecture for prediction of preeclampsia. I hope my screen is visible.
Yes, it's visible.
Yeah. So screening for preeclampsia is a very important thing. As Dr. Tabassum said, right from the day we all join our PG, it is one dreaded thing that everybody is scared of, I would say. And this is the world map showing the burden of the disease. It is not only we that we are scared of the disease, it is spread all over, especially the sub-Saharan countries. And the world map, you can see we all have been seeing, and that is how we screen our patients till now. There are certain traditional methods where we take the history, we take the signs and symptoms, we get over to the lab tests, and then we have got certain things that we add on to it. Certain ultrasound things also have come up, and then we add to those things and see where does the lady stand. Now, to add to it, our Foxy has also worked upon it on our local population, and they have come up with Foxy Gestosis ICOG hypertensive disorder in pregnancy a guideline, where we take a number of risk factors in the history, and then we put some score to it, and then add up all those scores. And then we say it is a mild EPH, that is the pregnancy hypertension, or is it a severe one? Is it an imminent eclampsia? Is it a fulminating one? Or is it a sure shot eclampsia? So we try to categorize this lady and then we try to make arrangements for her further visits or her referral and then try to save the baby and the mother. Now, these risk scorings have got certain international standards as well. They are the NICE guidelines and the ACOG guidelines that we all follow. What exactly do we see in that? We see, does that lady have a previous history of a preeclampsia or chronic hypertension, or does she have a chronic renal disease or diabetes or SLE or antiphospholipid antibody syndrome, such kind of a history? Or is this her first pregnancy? Because primaries, we all know they have got a greater incidence. What is her age? What is her BMI?
There's some network issue.
Yeah, network issue. I think Dr. Smita, we can't hear you in between. Dr. Smita? We can't hear you.
Madam, I think she's out of network right now.
Some network issues there. I'll call her.
No, she's calling, ma'am. Manisha is calling, I think. Dr. Manisha, can you call? Dr. Purnima, can you call Dr. Smita?
Yes, ma'am. She's trying back, ma'am.
Okay. Bela, ma'am, can we have the other talk first, if you permit?
I don't mind. I can start. My talk is second. I don't mind if she has some network issue.
Yes, she has a network issue.
So I can start my talk first. I don't mind.
Manisha, can you call her that we are starting the second talk?
Okay.
Yeah, so that by the time probably she can change the place where she is.
She's joining us. Yeah.
Sorry?
She's joined. I said she joined back.
Okay,
Okay.
she's joined.
Okay.
Right.
We continue.
So
I think I'm there again.
yeah, you are there.
Yes, yeah.
I'm so sorry for this. I'm really sorry for that.
You can start sharing again.
Yes, it's coming up. Is that okay?
Yeah, we are not able to. Yeah, now we can see the slide here. We are on the 11th slide right now.
Yes, the Fetal Medicine Foundation one.
Yeah, yeah.
Yes.
Put in a
Yes.
slideshow.
So I was.
Can you make
it's there?
Yeah.
Okay.
So we're speaking about the personalized risks that Fetal Medicine Foundation has come up with. What exactly does it do? It takes the maternal risk factors. Along with that, it takes the uterine artery PI. It takes the maternal mean arterial blood pressure. It takes the serum biochemistry, and it would add all of the things. And then it gives a personalized risk for that mother for that particular pregnancy. And when we take this personalized risk, it gives us the prediction for 90% for a preeclampsia development at less than 34 weeks, at less than 37 weeks, up to 75%, and for preeclampsia more than 37 weeks, 40%. So this gives us a very better prediction as compared to other meds. Now, there has been a multi-center screening, multi-center trial, I would say, where they have seen that the NICE guidelines, the ACOG guidelines, and the FMF, when they have compared all of them and tried to see how they pick up these preterm preeclampsias and the term preeclampsias, the FMF guideline could pick up almost 100% of them at less than 32 weeks, 75% at less than 37 weeks, more than 37 weeks, 43%. So it says that this multicentric trial says that the combination of the maternal factors, the mean arterial pressure, uterine artery PI, and the serum biochemistry of PLGF, it is far superior to the methods which are recommended by NICE and ACOG. So definitely we have to add more to the history. Now what exactly are we doing? We take these biomarkers for preeclampsia. So this biomarker first is the preeclampsia is mean arterial pressure. So we take the blood pressure by the automated machines. So these are validated automated devices. We take 2 measurements in each arm. An average of 4 is taken. And this average is expressed in multiples of millions, mons. Next, we go over to measurement of the uterine artery PI. I hope the video is clearly visible. Now, it is very important that we follow the protocol for measuring this uterine artery PI. So when we are taking this, the transducer has to be tilted from side to side. The color flow mapping is used to identify each uterine artery along the side of the cervix. And then it is at the level of the internal os. We take a sagittal section of the uterus and the cervical canal has to be seen. The sample gate has to be 2 to 3 centimeters so that it covers the whole vessel. The angle of insonation has to be less than 30 degrees. And the sweep speed for the waveforms should be 2 to 3 centimeters per second. So that the waveforms are nicely spread so that we can assess them better. This is how the waveform should be seen. And this is how we measure the uterine artery PI. We put it in the automated software and we get the mean uterine artery PI. The next thing that we see for the serum biochemistry is PLGF. PLGF is placental growth factor. So PLGF is synthesized by the placenta and it is a potent angiogenic function and it is lower in preeclampsia. It is because of the placental hypoxia. It is dependent on the maternal factors and the machine which is used for its measurement. So it is very important which lab do we choose for our serum biochemistries. It should take into consideration all the demographic factors, the mother's history, and then this thing will add to our screening. One very important other marker is serum soluble FMS-like tyrosine kinase. So such a long name, we just call it as SFLT1. It is an anti-angiogenic factor and it has a central role in pathogenesis of PE. So it is dependent on maternal factors and the machine which is used for its measurement. And very important thing that in established preeclampsia mamas, this serum SFLT is increased. And a very important point, this increase precedes the development of the disease by about 5 weeks. So we have got a very long time to know this thing and 5 weeks is a pretty long time for us to work upon. So this SFLT1, if I take it at first trimester 11 to 13 week, the studies say that along with maternal factors at 11 to 13 weeks, it does not improve the prediction. But yes, by 22 weeks, if I'm taking it, it helps me in prediction for PE at less than 32 weeks. If at 32 weeks I am seeing it, it is useful for prediction of PE at less than 37. So after 22 weeks, it is helpful for me if I see this SFLT1. Another one is PAPA, the pregnancy-associated plasma protein A. This also has got an important role in placental growth and development. And we all do it when we are doing a double marker, the Down syndrome screening. It is decreased in pregnancies with fetal trisomies 21, 18, 13. And the pregnancies that develop preeclampsia, the maternal serum PAPA is less during the first trimester. It is not significantly different in second trimester and it increases in early third trimester. So this PAPA is also incorporated in screening for preeclampsias. So when I'm screening a lady at 11 to 13 weeks, what do I do? Or what do I want to do? I screen her and I start her with prophylactic aspirin. That I'll speak a few slides later. So what I'm doing at 11 to 13 weeks, I'm seeing the mean arterial pressure, I'm seeing the uterine artery PI, I'm seeing the PLGF. This is the combined screening. And this combined screening is helping me to predict the preeclampsia less than 34 weeks of gestation up to 90%. A pretty good number. If I screen the lady at 20 to 24 weeks, because my screening will never stop during the whole of the pregnancy, and suppose a lady is coming to me late, or even if she is my follow-up patient, I will see her again at 20 to 24 weeks for PE. It is to estimate the patient-specific risk for developing PE. I have to see the subsequent management of this pregnancy including the timing and the content of the subsequent visits. And in pregnancies that develop the preeclampsia in second trimester, the values of MAP has to be taken, the uterine artery PI has to be taken, and as I told, the SFLT1, they are increased, the PLGF is increased. So if I'm incorporating these things, my prediction for preterm preeclampsia is 100%. So my screening never stops. At 30 to 34 weeks also I will see. But here, as you can see the table, if I'm taking the mean arterial pressure, PLGF and SFLT1, it is 97%. And adding to it the uterine artery PI, it just gives me 1% more, 98% only. So now the uterine artery PI is not helping me much. Here the serum biochemistry along with the maternal demographics and the mean arterial pressure is helping me enough. Screening at 35 to 37 weeks also. Here also the table, you can make that out, that uterine artery PI does not add much to it, but the MAP and serum biochemistry is helping me in screening them. So if I summarize all this, what I have spoken till now, 12 weeks, 22 weeks, 32 weeks, and 36 weeks. If this 4 times, if this lady is coming to me, I have to see the mean arterial pressure all the times. Uterine artery PI, I have to see at 12 weeks, I have to see at 22 weeks, I have to see at 32 weeks. PLGF all through. SFLT1 starts from 22 weeks, 32 weeks, and 36. PAPE only at 12 weeks. There is another concept of maternal cardiac function, that is, it is reduced. There's impaired placentation, placental hypoxia, release of anti-angiogenic factors, endothelial cell dysfunction, but this is for the late preeclampsia that happens. The reduced placentation or a dysfunctional placenta, it is for the early onset preeclampsia that happens. Now, ophthalmic artery Doppler is another weapon in our armamentarium, I can say. This ophthalmic artery Doppler is the artery, it is the first branch of the internal carotid artery, and it is embryologically, anatomically, and it has got functional similarities with the intracranial vasculature. So the Doppler assessment will give me information of the intracranial circulation, which otherwise I don't have access to. And in the pregnancies which develop preeclampsia, there's a decrease in the PI and increase in velocities. So there have been a lot of studies going on, and they have come up with a ophthalmic artery Doppler assessment for these mothers now. And we just put the linear probe over the eye of the mother, and we try to see interrogate the ophthalmic artery. And this is how we see the ophthalmic artery Doppler. This is the kind of waveform we get. We get 2 peaks over it. So the mother is in the supine position, 16 to 15 hertz linear transducer is used. And there are certain protocol that the way it is to be seen. And if I put more in a simple way, we take a ratio also and a PI also. So they say that before the development of preeclampsia or gestational hypertension, the ophthalmic artery PI is reduced and the second peak velocity is increased. So we need to have more studies from our side these days to perform, and more number of people should come up with doing ophthalmic artery Doppler to assess the intracranial vasculature, the problem that may happen with the eclamptic patients. So ophthalmic artery Doppler also comes into this table of my summary now, that it can be done at 22 weeks and at 36 weeks as well. Now, when I have done this prediction, what am I going to do next with that? So there has been a very beautiful ASPRI trial. We all have implemented, I would say. So FMF algorithm, when they had done this implication that once the mother is screen positive and the estimated risk for preterm preeclampsia was more than 1 in 100, then they had added aspirin 150 milligram per day. So a number of patients were given 150, and then there was a placebo, and this is how the trial was conducted. And then they saw a reduction of 89% for preterm preeclampsia. Less than 32 weeks. For less than 37 weeks, there was 62% reduction. But the compliance has to be up to 90%. The mother has to take the tablet every day starting from first trimester till 36 weeks. And one very important point is that the beneficial effect of aspirin is dose dependent. So the greater reduction in incidence of PE was seen when the dose was more than 100 milligram. So this 150 milligram has been set, and this gives us the best result. Before 16 weeks, it has to be started. So it is very important that first trimester scan that we're doing, the NT scan, that is the time that I do the screening for preeclampsia and I start with this thing so that my purpose is solved. So screening for preeclampsia, this is a lovely table which summarizes the whole talk. Mean arterial pressure every time, uterine artery Doppler, first trimester, anomaly scan, 32 weeks growth scan, PLGF all through. SFLT1 starts from 22 weeks onwards. And if somebody is able to do, ophthalmic artery ratio at 22 weeks and 36 weeks. Thank you. Thank you very much.
Thank you, madam. Thank you, Dr. Smita. Shruti is there?
Welcome.
Yeah, can we just wait for 2 minutes? Dr. Komal has joined. Our guest of honor has joined. So as soon as we, finish her address, we will come back to first session and the comments again. Dr. Komal, we are waiting for your address. Is she there?
Is she there, Dr. Komal?
She was there. I'm calling her. I think the chairpersons can conclude the first session.
Yeah, before they conclude, I would just like to thank Dr. Smita Dengre, who is a dear friend and a committee member of Imaging Science Committee, for accepting this invitation and for a wonderful talk. So I am extremely thankful to both Dr. Smita Dengre and Dr. Priya Deshpande, who are my committee members, and for accepting the invitation to speak on such wonderful topics. Thank you, Dr. Smita.
Thank you so much. Thank you so much, Dr. Smita, and thank you, Bela ma'am, for your committee total committed involvement. I think Dr. Komal is not picking up the phone. Manisha, you can try.
Yes, ma'am. Yeah, she's not.
And we are waiting for chairpersons, Dr. Shruti and Dr. Tabassum, for the concluding remarks for session 1.
First of all, I want to
thank you,
Monica Didi, and I want to thank Manisha, who has been tireless and diligent. She made sure that everyone should join and in time. Having said that, now I come to the star of the first session, our Smita. Oh my God, Smita, I have been dying to meet you since so many days. I could not meet you in Harda, but then I want to congratulate you from this platform.
Thank you.
First, I want to
Thank you
tell
so much.
that Smita has been a phenomenal, she has brought about phenomenal change in my management of such patients in my practice. और हमारे पूरे
Thank you so much.
में रहती है, and all my patients, wherever I have a doubt, she is the go-to station for me. And we have.
Thank you so much. Thank you.
स्मिता, पता नहीं मैंने आपको बताया कि नहीं, so many patients जिसमें अपन ने first trimester के बाद we started them with ecosprin and all, and they have developed, they have delivered nice plump Murphy babies, and nicely. So I thank you for that, and this was
Thank you, ma'am. Thank you so much.
important topic, and the right person to speak about it. So again, congratulations, Monica Di and Manisha. And we should all congratulate Smita for one more thing, which I know you all know. She has won the prestigious bodybuilding championship. I was so pleasantly shocked.
Congratulations.
Pleasantly shocked when I saw this. कि ये लड़की क्या करती है? So congratulations, Smita. And
Thank you so much.
You are changing the world for better. Thank you, Monica.
Thank you so much. Thank you.
Thank you, Dr. Smita. Your talk was like a burst of sunshine in this cold winter evening. So we enjoyed it a lot. My only question is, PLGF, you mentioned it all through the trimesters. So do we need to do PLGF again and again and again?
No, see, once we have done it in the first trimester and we do a combined screening. So there, if we are getting it done from a good lab, they will combine for you. Or if you're using the software, you get a combined risk assessment for preeclampsia. And then you start with the aspirin. And then you keep your patient under surveillance for blood pressure and her uterine artery PI and the growth of the baby. So that serves your purpose.
Yes, but
apart from that, if you see that he has the
We have
Yes,
Komal madam
again and
with
again we are
us.
not seeing. Then you will add SFLT. Then if she is
Yes.
really with the past history or her numbers are really very high, then you add SFLT to that. That gives you prediction for the next 5 weeks. So SFLT here comes to your help. Suppose if this patient had not had anything prior, then that PLGF comes to your rescue then. If she has
Okay,
not
and many labs, they
had
are
a
not
first
doing
trimester
PLGF
screen.
after the first trimester. They are refusing PLGF after first trimester.
Yes, I mean the standard labs, they'll help you out with the SFLT one there. So
Yes.
that's why I always give a
That is a
insistence
practical
that
problem we are
go for a
facing
good
here.
good
Yeah.
lab is always required. Yeah, because they'll be knowing what you're asking for. So then you ask for a SFLT one if she has crossed the second trimester.
All right. Okay. Thank you so much for the insights. Thanks.
Welcome. Welcome.
So now we
Thank you
have the
for your
pleasure
first.
of welcoming our guest of honor, Dr. Komal, who was busy with the meeting. I take great pleasure in inviting Dr. Komal Chavan to Symbiosis 4. As I mentioned, that Dr. Varsha Baste and Dr. Komal Chavan had a very tough battle for Foxy Vice President, though it was a friendly sort of battle, but still the best had to win. And Dr. Komal, despite people always say that Mumbai people have an advantage, but I tell every one of my friends that it's because of their grit and determination and hard work. They don't sleep, they sleep lesser than us. I think they eat also lesser than us. They network more than us. They have they are in a big city, but that city is like relentless. Bombay doesn't sleep. So I feel that every person who wins from Mumbai is actually a star. Madam, congratulations for Vice President elect Foxy 25. Madam has headed so many committees in MOGS, AMOGS, and Foxy. She is a keen academician, and so many of our students got awards and prizes in front of me in Femtech 4. So she's a great DNB teacher. Her students are doing wonders, and she is the medical director of Chavan Maternity and Nursing Home, recipient of several prizes from MOGS, Foxy, and Appreciation Award from the Maharashtra government, recipient of Dr. TK Award and Foxy Youth Mela Appreciation Award. We welcome you, Komal ma'am, amongst us, and we would love to have a few words from you.
Thank you so much, Dr. Monica. And Monica is the one person who is really very nice, nice at heart. And she does her things very meticulously. And I'm so honored and happy to be a part of your program. I really was in an MOGS managing committee meeting and was caught up in that. And that is the reason I couldn't join during the formal inauguration. But it is always a great pleasure to be on this platform of Foxy and Foxy Imaging Science Committee under the leadership of Bela Bhatt as the chairperson is doing just wonders. So she is our go-to Mumbai girl. So we are very happy and proud of her. Regards to Dr. Rishikesh Pai, Dr. Madhuri Patel, the Foxy entire team of Imaging Science Committee and the conveners Monica and all the Bhopal to have a program with the Bhopal Obstetrics and Gynec and the Bhopal Menopause Society. It is a real great collaboration. I think such interesting programs and interesting topics you have selected, they are such lovely, the academic knowledge which you are spreading is the most important thing. And that also from the right person you have selected for every topic. I just joined at the end of the first talk and loved the discussion which was going on the markers and, how you can actually go and diagnose preeclampsia, what are the newer modalities and the advances. So that is actually what is the need of the hour. And so many, I think Tabassum and other people, I had so many, I'm meeting them virtually, but I have met them physically when I was moving around in campaign. So I'm really happy. Varsha Lade also will join soon. Manisha Jain, she's coordinated like fabulously. She has been calling us, all the time, every time, and making us comfortable. So I'm not going to take more time. Thank you but so really much. happy, and I wish this program all the best. Thank you so much for having me as a part of the program. Best wishes for the program. Thank you so much.
Thank you, Dr. Komal. Thank you. Thank you so much for your kind words, and always a kind word, a word of encouragement, a big support, and a friend always. Thank you so much, and all the best for your future in Foxy, AMOGS, MOGS, ISAR.
Thank you. Thank you. Bye. Thank you so
Thanks.
much, ma'am, for blessing us. Thank you so much.
So can we go to session
Yeah.
two? No, I think chairpersons have commented on Dr. Smita's talk. Comments are over?
Yes, ma'am. Yeah.
Okay. Okay, let's move to session 2. Yeah.
Okay. So now we move on to the next session, and that for the next session we have none other than Dr. Bera Bhatt Madam with us, who is the chairperson Foxy Imaging Science Committee, and she'll be talking on basics of Doppler in obstetrics. And to chair the session, we have with us Dr. Varsha Lahari Madam and Dr. Padma Shukla Ma'am. Dr. Varsha Lahari Madam is the president of Nasik Obscurity Society. I welcome you, ma'am, and the zonal coordinator of AMOX. She has been the past organizing secretary of the NOGS and past joint secretary of IMA. Welcome you, ma'am. The next we have with us is Dr. Padma Shukla, ma'am, who is associate professor currently, and she has special awards and achievements to her credit. She has received Best Paper Award in AICOG and in Young Talent Award and Dr. Durusha Award as well. And she has many publications to her credit. Over to chairpersons now for the next talk. Thank you so much.
Should I share the screen? Should I start?
Madam, they have to read your CV.
Good evening.
Yeah.
Hello.
Can we
Yes,
have
ma'am.
Bela ma'am CV, please? Bela ma'am CV, please. Yeah. Thank you. Dr. Varsha Lahade, you can.
Can I start? Yeah.
Yes, please, please.
Yeah.
please.
Can I start?
Yes,
I
yes.
was just waiting for some. Okay. Hi, everyone. Good evening. And it's my proud privilege to introduce Dr. Bela Bhatt. Everyone knows Dr. Bela, a great, I cannot tell as an dancer, but she's really a great artist, as you said, Monica. Yeah, lovely dances we have already seen at many places. Yeah, she other than that, she is a chairperson for Foxy Imaging Science Committee 2021 to 25. Yes, I know her as an consultant at Bela Women's Hospital and fetal medicine expert at Andheri, Mumbai. And as Dr. Monica has already introduced her, I don't waste my everyone's time. She's excellent orator also. I've seen her debating and as well taking the panel discussion excellently and taking and give the message adequately as a moderator. I really respect and honor her being a chairperson for Foxy Imaging. Welcome, Dr. Bela, for your talk. And I know you are going to mesmerize everyone out here.
Thank you so much, Dr.
Over
Varsha
to you,
Lahade, for those kind words. Dr. Varsha Lahari has also been a very good friend of mine, so that partiality could be seen. Okay, I'll just share my screen first. This comes in my way. Just give me a minute. I'll make it full screen. Is my presentation seen? No?
Not right now, ma'am. Not right now.
Resume share now.
Now
Yes,
it's seen. Yes, ma'am.
Okay, and you are now. I'll have to put it down so that I can share. Okay. So thank you so much, everyone, for those kind words. And it's always a pleasure. We all are good academicians. We all are dear friends, and we all work in harmony to try and improve the outcome of pregnancy for both the mother and the fetus. And that's how the Foxy works, and that's the reason we are all here bonded together. So without much ado, I would like to start my talk, and that's on normal fetal Doppler sampling. So when me and Dr. Monica, we were discussing about the topic, I just asked Dr. Monica, what do you want? You want the technical part of Doppler, or you want the use of it? So she suggested, yes, we should have a mix of both. And that's what is important. When we are talking about any modality, ultrasound we know has a central role to play nowadays in management of pregnancy. But fetal Doppler Madam mentioned just now that it's like a ultrasound is like a stethoscope. So fetal Doppler is like a colorful stethoscope, because we know that without fetal Doppler, we'll come to know through the talk also that how useful it is in many, many conditions to try and predict and prevent some of the complications, manage some of the complications. So we are going to see the same through the talk. So knowing how to do and how to use, both are equally important, because unless until you do it well, you're not going to get the proper parameters, and you're not going to be using them properly in management of pregnancy. So we'll see both the arms. So we must first know about the normals, how the normal Dopplers look, and then we should try and find out what is deviating from it, that is abnormal. So when we are talking about Dopplers, the first thing, most important basics, is we must know about what is S, that is systolic velocity, what is D, that is diastolic velocity, and there are various indices, S by D, PI, and RI. But now we know for sure that the most important parameter of all index is pulsatility index, that is PI, which is S by S minus D upon mean. Now, why is this important? I would like to tell, especially in fetal growth restriction management, because previously we used to use S by D ratios. Friends, we do not use it anymore, because if the diastolic flow is 0, it will become infinite. It will not give us any answer. So we do not use S by D. What we use is pulsatility index, or PI, in umbilical artery, in MCA, everywhere, right? So this is absolute basic. When it comes to clinical utility of obstetric Doppler, I'm going to discuss it trimester-wise as well. We'll talk vessel-wise as well as trimester-wise. So we know that these days we do a nuchal scan in the first trimester, around 11 to 14 weeks, where we try to do aneuploidy screening, in which we need Dopplers because we need ductus venosus and tricuspid. We want to predict preeclampsia and fetal growth restriction, which we can do along with uterine artery PI, along with biochemistry, as Dr. Smita has beautifully explained. And of course, we also look at the heart in the first trimester with the help of Dopplers. In second and third trimester, we use these Dopplers for diagnosis and management of fetal growth restriction, for fetal anemia management, and of course for cardiac anomalies. And this is with the help of multi-vessel Doppler, which is umbilical artery, middle cerebral artery, ductus venosus, uterine artery, and of course the fetal echo. Now this fetal echo I'm just showing at third month also can be so good, right? We can see the cardiac structures very well at third month. But I am not going to discuss about this fetal echo in this talk, because it's a separate topic in itself. Again, Dopplers in twins, special situation, teratoma, placental tumors, dilated vein of Galen, a special situation which I won't be covering. What I'll be covering today is absolute basics, which we can start working with, and we can manage our patients better. So we must look at each vessel trimester wise, because every vessel gives us some information, that is uterine artery, umbilical artery, middle cerebral artery, and ductus venosus. Now, the uterine artery will tell us, we know that uterine artery enters from the maternal side, so it is going to tell us about the resistance in the placenta from the maternal side, whereas umbilical artery comes from the fetal side, so it tells us about the resistance in placenta on the fetal side, whereas the middle cerebral artery in the brain of the fetus will give us two information as to how hypoxic or how anemic the fetus is, and ductus venosus tells us how good the fetal heart is, or the fetal heart function is. So this is the information each vessel gives us. Let's start with each vessel and try and find out what each vessel teaches us. As far as uterine artery is concerned, we learned, we unlearned, and we relearned. Previously, we thought that it is just used for prediction of preeclampsia and fetal growth restriction at our nuchal scan or 11 to 14 week scan. But now we know that it has a role to play throughout the pregnancy, because we now also use it for the diagnosis and prognostication in fetal growth restriction in second and third trimester as well. So just basics of this, we all know there are two waves of trophoblastic invasion. The first one between 8 to 10 weeks in the spiral artery, and the second one between 16 to 18 weeks. And the second one, which is very, very crucial, which converts the high resistance uterine artery into a low resistance system. And that is how the entire pregnancy is sustained. The fetus gets the proper blood flow and oxygenation. It is a must change for a pregnancy to progress normally. But what happens as the pregnancy advances, the trophoblastic invasion in the uterine artery, so spiral artery increases, and the resistance reduces further and further. The diastolic flow increases further and further. So if you see, look at the uterine artery waveform at 11 to 13 weeks, the diastolic flow is less, the PI is higher. As you progress in the second trimester, between 18 to 22 weeks, the diastolic flow, as you can see in comparison with the first trimester, improves and the PI drops. And in the third trimester, because the vessel is very low resistance, there is a very good diastolic flow with still further drop in the uterine artery PI. This is what should normally happen in a normal pregnancy for the fetus to get proper oxygenation and blood flow. But what if this change doesn't occur? What if the trophoblastic invasion is defective? Then the vessel doesn't convert into low resistance system. It remains the same high resistance system. And that leads to problem like preeclampsia and fetal growth restriction. And this is what we can predict at 11 to 14 weeks. This, as you can obviously see, the diastolic flow is very, very low. The uterine artery PI is very high. But remember, we never rely on one side uterine artery PI. We always do a mean of uterine artery PI, because the side on which there is placenta, the PI is going to be lesser. The opposite side, the PI is going to be higher. So we take a mean of both uterine artery PI and use it for prediction of preeclampsia. Now, because we are also going to talk a bit about the technique of Doppler, remember, for any Doppler technique, there are a few basic principles. That is, you have to zoom the area of interest, whether it's uterine artery, whether it's umbilical artery, whether it's middle cerebral artery. Then we have to apply a color Doppler, then narrow the color box, apply the pulse wave gauge, adjust the gauge to cover the vessel, and adjust the velocity scale and filter, and then take 3 consecutive uniform waveforms in the absence of fetal body and breathing movements. Now, as you can see, uterine artery Doppler, Dr. Smita has already shown, but I'll just repeat it just to show you that we take a mid-set section of the uterus and cervical canal, and that the curved tertius vessel, which is seen on the either side of the cervix, is nothing but the uterine artery. And then you apply the gate, as I mentioned in my previous slide, to try and get the uterine artery waveform. So when you do any kind of Doppler, it's extremely important to see that the angle of insonation is less than 30 degrees. And why is this important? Because the ratios are independent of it, but the peak systolic velocity is dependent on this angle of insonation. So always correct. Try and take the vertical portion of the artery so that you don't have to correct much. But if at all you don't get, then you have to correct that angle less than 30 degrees so that you get a correct PSV and so the correct values of all parameters. Okay, so this is how we take the uterine artery PI. As I said, we take mean of both uterine artery PI, and if the mean of uterine artery PI is more than 95th centile, along with the maternal demographic factors and mean arterial pressure, it is going to tell us about the risk for early preeclampsia and fetal growth restriction. Now, it's extremely important as to why uterine artery PI has to be included in this calculation, because when we look at the sensitivity of prediction of early preeclampsia at nuchal scan, just the maternal demographic factors and mean arterial pressure, the sensitivity for prediction is 50%. When you add uterine artery PI, it suddenly increases to 75%, which is good enough. Even in the remotest area, I think these days, we have basic ultrasound machine with basic Dopplers. So at least we can take the history well, maternal demographic factors. We can take mean arterial pressure with Hertzsprung manometer, and we can do a uterine artery PI at 3rd month. And the sensitivity is 75% to pick up this. We all know early preeclampsia is the severe most form of preeclampsia. And if we can prevent, we can predict and prevent this, then we'll see less of those severe preeclampsia, eclampsia, HELLP syndrome, everything at term or in the second half of pregnancy. And that's very, very important, even in the rural areas, which makes 70% of India. When you add PAPE, which is usually a part of our double marker along with the nuchal scan, slight improvement in sensitivity. But when you add PLGF, as Dr. Smita mentioned, there is still better prediction, almost 90% prediction of this early onset preeclampsia. And therefore, wherever feasible possible, we nowadays use this PLGF. But I always try and say that whatever is possible, do in your area. If you have feasibility of possibly, economically patient can get PLGF done, fine. Otherwise, you are doing your double marker and a nuchal scan, at least 75 to 80% sensitivity you can get for prediction of preeclampsia and fetal growth restriction. So do what is least possible, but use this parameter. Now, risk calculation for this, after having done your mean uterine artery PI, we all know that online we have this calculator available by Fetal Medicine Foundation, wherein you just have to put in all the values, weeks of gestation, the demographic factors, the mean artery pressure, and the uterine artery PI. And if you have biochemistry, just feed in. It is available online, and you will get your risk calculation for preeclampsia. And if it is more than 1 in 150, more than 1 in 100, then we start with the 150 milligram of low dose aspirin at night and continue till 36 weeks. And we see 90% reduction in the severe form of preeclampsia, which I think is a great thing. I'm sure everybody who's working in many of the government hospitals still see so many of severe forms of preeclampsia. So if we can prevent that also, that will have a great impact on reducing maternal morbidity and mortality. Now, what is the role of, just one slide on this, role of uterine artery PI in second trimester? Well, again, it has very good specificity of 95%. So if I see a good uterine artery, the diastolic flow and low uterine artery PI, mean uterine artery PI at my 18 to 22 weeks, then I'm little reassured that most probably this patient will not develop complications like preeclampsia or fetal growth restriction. Now, just quickly, because we are talking about Dopplers, we use ductus venosus and tricuspid regurgitation, tricuspid flow as aneuploidy markers. And I'm not going into details of these markers at present, but these are not just markers for aneuploidy. But remember, when you have A-wave reversal in ductus venosus or tricuspid regurgitation, these are also markers of cardiac anomaly. And therefore, we have a look at the heart closely when we get these markers along with the high NT, and they are also markers of fetal demise. So they give a lot more information. We now move on to the other artery, that is umbilical artery, which is very, very important artery as far as Dopplers is concerned. And we know this concept of pump, pipe, and receiver. The fetal heart is the pump, the umbilical artery is the pipe, and the placenta is the receiver. Now, so what happens is when we take the umbilical artery waveform on Dopplers, when we get the waveform, the systolic velocity is determined by the cardiac contractility of the heart of the fetus, and the diastolic flow will be decided by the resistance in the placenta. Right? So this is what is important. Now, as far as a technique of umbilical artery is concerned, again, we use the same principle as I told you. We zoom the area of interest, and then we narrow the color box and put in the gate inside the umbilical artery. And this is how we get the waveform of umbilical artery. Now, remember always that in umbilical artery, the diastolic flow is usually good and PI is less as compared to when you compare it with the middle cerebral artery. Now, what is the role of umbilical artery? So, let me tell you that we have two types. I'm not going to details of fetal growth restriction. It's a very long topic, but just a basic thing that in early onset fetal growth restriction, there's a lot of placental involvement, whereas in late onset fetal growth restriction, less than 30% of placenta is involved, right? So you'll get more of umbilical artery abnormalities in the early onset fetal growth restriction. So it helps in diagnosis of early onset fetal growth restriction, but you won't see much changes in umbilical artery Doppler in late onset fetal growth restriction. So this one, particularly helps in identification of fetal growth restriction, differentiate between small for gestational age and fetal growth restriction, wherein you will find abnormalities in umbilical artery, whereas in small for gestational age, which are constitutionally small, you will not find it, and also helps in monitoring and timing of delivery. So I have a slide on the same also, but it will not help you in the late onset fetal growth restriction. Now, normally what happens in umbilical artery is there is progressive increase in the diastolic flow trimester wise. So there is fall in PI. But when there is fetal growth restriction, placental insufficiency, you'll find that there is proportionate decrease in the end diastolic flow. There will be changes in the waveform. Now, this slide is, I think, extremely important for us to understand because it directly tells you how much of your placenta is functioning. So when you have the umbilical artery PI, which is more than 95th centile, but the diastolic flow is still positive, then this is the diastolic flow, as you can see, which is still present there. So you can find out that 30% of placenta is affected, rest 70% is still functioning well. When there is end diastolic flow, there is no diastolic flow in this, right? So there it tells us that 50% of placenta is not functioning well. But when there is reversal of this diastolic flow, it tells us that 70% of placenta is not functioning well. So this is so crucial. So I always request everyone who's doing ultrasound, as well as those who are getting ultrasound done from a sonologist, don't just read a report, have a look at the images as well, because images speak a lot. They'll tell you directly how much of the placenta is functioning and how closely you need to monitor these patients, right? So this is extremely important, and these parameters are used when we talk about stage-based management of fetal growth restriction by Barcelona, which I'll cover just after I complete my middle cerebral artery. Now, the middle cerebral artery is, I would say, very sonologist friendly. It has role mainly in second and third trimester, easy to do, reliable, and very less inter-observer variability, provided it has been done in a standard manner. So what do we do in this? An axial section of the fetal head is taken where both the thalamic and cavum septum pellucidum is seen. Circle of Willis is visualized, and then what we do is MCA closest to the maternal spleen is chosen, and the gate is placed over the vessel just as it bifurcates from the, as it bifurcates from the carotid siphon, and then measurement is taken preferably from the proximal portion and not the peripheral, because there'll be lower velocities there. Now, as far as middle cerebral artery is concerned, yes, we look at the PI, but what is more important is the ratio of MCA PI upon umbilical artery PI, which is a cerebroplacental ratio, because it is more sensitive than middle cerebral artery PI as far as the prognostication or the fetal growth restriction is concerned. Now, when the CPR is less than 5th centile, it tells us that baby is hypoxic, but baby is trying to compensate. There is a brain sparing effect when the MCF. So normally in MCA PI, I should have a high MCA PI because the diastolic flow normally is lesser. But when the baby is trying to compensate by the vasodilatation, by the brain sparing effect, you will find that the diastolic flow increases like this, and therefore the MCA PI falls. So in fetal growth restriction, the umbilical PI is going to increase, MCA PI is going to fall, and therefore CPR is going to go less than 5th centile. Now again, CPR has a different meaning in early onset fetal growth restriction and late onset fetal growth restriction. Early onset fetal growth restriction, which develops before 32 weeks of gestation, it just tells us, if the CPR is less than 5th centile, it just tells us that baby is trying to auto-regulate, but the fetus can still cope up. It doesn't tell you, it is not a trigger for delivery in early fetal growth restriction. Whereas in late fetal growth restriction, it has a very, very crucial role, because CPR less than 5th centile gives a red flag after 32 weeks, and it tells us that this baby is not going to tolerate this hypoxia. This is a term fetal growth restriction, and therefore baby will not be able to tolerate the minimum hypoxia also. So monitor closely with daily fetal movement count, CTG and NST. to avoid late stillbirth. Friends, let me tell you, out of all, 40% of late stillbirths are because of late onset fetal growth restriction, which is a milder form, but we are not able to pick them up, and therefore we find that we can't find out the reason for stillbirth, but actual reason is late fetal growth restriction. So there's a crucial role of doing Dopplers at 32 and 36 weeks. So both umbilical artery, the middle cerebral artery, CPR, has a very, very important role in diagnosis of fetal growth restriction by international Delphi consensus, as we use in early and late. I'm again not going to details of this, but we all diagnose fetal growth restriction based on this Delphi consensus, for which we have to have these multi-vessel Dopplers. Otherwise, we can't pick up fetal growth restriction. I'll need 1 hour if I have to discuss this, so I'm just cutting it short. Again, when we are trying to decide when to deliver this fetal growth restriction based on stage 1, 2, 3, 4, it uses all these umbilical artery, whether it's more than 95th centile, always there is absent end diastolic flow in umbilical artery, or reverse end diastolic flow in umbilical artery, or A-wave reversal in ductus venosus, stage 1, 2, 3, 4, which tells us when to terminate the pregnancy at 37, 34, 30, or 26 weeks, right? So we need all these multi-vessel Dopplers if we have to manage this. And friends, believe me, if we follow this chart, we'll significantly reduce the fetal demise because of fetal growth restriction. Only thing, the Dopplers have to be done in standard way. Their interpretation has to be proper and action has to be taken. Now, as far as technique for middle cerebral artery is concerned, remember, middle cerebral artery PI is one parameter, but another important parameter is middle cerebral artery PSV, which is peak systolic velocity. Now, why is this important? Because it has important role to play in diagnosis of fetal anemia. And therefore, when we are trying to use this for fetal anemia for middle PSV, remember the angle of installation has to be less than 15 degrees. Because otherwise your PSV is going to be wrong. And we are, why do I say that it is sonologist friendly? Because usually in the BPD plane where we try and find out the middle cerebral artery, usually the angle of installation is between 0 and 15 degrees, and therefore we get the correct middle PSV. But there has to be no fetal movement or no fetal breathing movement to get a proper middle cerebral artery PSV, and then we use the middle cerebral artery MCA PSV MOMs to try and find out whether the baby is anemic or not, because we know in anemia the MCA PSV MOMs would be more than 1.5 MOM, which will tell us. So there are some charts which are available which can tell you, or roughly if you want to get idea about MCA PSV, you can get idea that if the MCA PSV is almost more than twice the weeks of gestation. So at 32 weeks, if I am doing MCA, and if the MCA PSV is more than 64, then it should be more than 1.5 MOM. And there is an urgent need for intrauterine transfusion, because MCA PSV is something which we use in fetal anemia, mainly in RH isoimmunization, RH negative mother, or fetal infections like parvovirus. So here, why is MCA PSV increased? Because in fetal anemia, we know that the stroke volume increases, the cardiac output increases, so there is hyperdynamic circulation. Not only that, because of anemia, there is reduced blood viscosity, and that also increases the peak systolic velocity. So more than 1.5 MOM again raises a red flag that it needs intrauterine transfusion. With this non-invasive method, we have been able to monitor the RH negative mothers who are isoimmunized, and we can do timely MCA PSV, and we have saved so many babies, and it has replaced the invasive method. Just quickly, so that I don't miss this technique for ductus venosus also, in first as well as second trimester. In first trimester, we use the sagittal section, in which we know the aliasing pattern, which is seen as it enters into the inferior vena cava, and there you put in the minimum gauge 0.7 to 1 millimeter, and you'll get this triphasic waveform of ductus venosus. And we know that this tiny A wave which is seen here is what is most important, not these big waves, 2 waves. Yes, it does tell us about the PI, but this, whether this A wave is positive or absent or reversal will give us prognostication, because it tells us about the right atrial pressure and how well the heart function is. So if we have a reversal of absent or reversal of A wave, it tells us that the heart is failing, and therefore it's an ominous sign. And whatever weeks of gestation it is, it will tell that the baby is about to die. And if it is in the second half, of course, we have to terminate the pregnancy and try and deliver the baby. It predicts acidosis in fetal growth restriction and tells us about the reduced cardiac compliance and myocardial ischemia, and it's a absolute trigger for delivery. So now that was about first and second trimester. Now, as I told you, the Dopplers at 32 and 36 weeks are extremely important, because it will tell us, it will help us pick up the late onset fetal growth restriction, which we are going to otherwise miss. So our umbilical artery, the middle cerebral artery, and ductus venosus and uterine artery, we have to do multivessel Doppler at 32 to 36 weeks. And I've showed you the chart. Unfortunately, I can't go into details of it, how to diagnose it, but you look at the chart and you'll be able to diagnose whether the baby is having late onset fetal growth restriction or not. And then you need to manage also based on that Barcelona management. Dr. Monica, I think we'll have to have another talk on fetal growth restriction, because otherwise I'll eat up third speaker's time also. So my point was just that, okay, that was about all Dopplers. Whenever we are talking about Dopplers, people, even many patients have this query, ma'am, is it safe? You're doing Dopplers so many times. Is it safe for my baby? So let me tell you that in last 20-25 years, there has been increase in the use of spectral Doppler and B mode imaging. But in obstetric applications, the Dopplers are absolutely safe. Only thing, we have to follow the LRR principle, which is as low as reasonably achievable. And therefore, we all try and minimize our usage of Dopplers, and to minimize it only to what is required. So just 2 points to ponder. Uterine artery helps us in prediction and prevention preeclampsia, and also in the diagnosis and prognostication of fetal growth restriction. Umbilical artery is a trigger for delivery of, in case of early onset fetal growth restriction. Ductus venosus, absolute trigger for delivery in fetal growth restriction based on the A wave. MCA and CPR has a crucial role in late onset fetal growth restriction. So there are so many cases which we can discuss over these Dopplers, but because of time constraint, I think I just restricted to the technique and where all we can use the Dopplers. And I know we all are functioning for one thing, and that's a final outcome. That's a healthy mother, healthy baby, and smiles on the mother of baby, for which we all have been working. And I think Dopplers are extremely important to have this final outcome along with that grayscale imaging. So with this, as a chairperson for the Imaging Science Committee, I always wish that every obstetrician should try and become a sono obstetrician and gynecologist, because every patient that walks in our chamber needs ultrasound. So we must refine our skills of ultrasound, and I have been working towards the same aim throughout my tenure. Thank you so much for patient hearing. Thank you.
That was really a comprehensive and beautiful, crystal clear picture of Doppler. She has quoted all the vessels. I think at the end of her tenure, she might come up with another vessel of the fetus, and she can tell you 100% now, go ahead with cesarean section tomorrow. That's really wonderful, Bela. You have covered all the vessels and importance of FGR. And if you don't want to be more towards the medical legal, you have to be best in the Doppler. So thank you so much. And thank you, Monica, for giving me opportunity. Thank you, President Foxy, Dr. Pai, everyone in the Foxy team. Thank you so much.
Thank you, Dr. Varsha, and thank you, Dr. Bela. I think we will put you now in Perfection series, because perfection goes very deep. So in perfection, we can have complete 3 hours of only Doppler, ma'am. There's no problem. So thank you so much, Bela, ma'am. Manisha, you can proceed.
Yeah, thank you so much, chairpersons. With this, we move on to the next session, that is third session, and that will be by Dr. Priya Deshpande, ma'am, who is from Mumbai, Fox.
Best Zone Coordinator of Foxy's Emerging Science Committee, and she'll be talking on second trimester anomaly scan. To chair the session, we have with us Dr. Sunita Vadvani, ma'am, and Dr. Anita Peter with us. I welcome you, ma'am. Dr. Sunita Vadvani, ma'am, is the president of Ratlam Obscanning Society and director and consultant of Ratlam Hospital and Research Center. She's also an NABH assessor and MBA in hospital and healthcare. She has a special interest in critical obstetrics, and she's the lead assessor and master trainer in Manyata by Foxy. Welcome, ma'am. Next, we have with us is Dr. Anita Peter, ma'am. She is a current Foxy president of Ujjain Society, and she was the ex-vice president of Ujjain IHA branch, also ex-Foxy secretary Ujjain branch, and master trainer for MTP and SBA. She has a special area of interest in infertility and high-risk pregnancy. Welcome, ma'am, and over to chairpersons.
A very good evening to everybody. I bring a very good regards from Ratlam Obstetric and Gynec Society. On behalf of Ratlam Obstetric and Gynec Society, I really thank you, Dr. Monica, ma'am, Dr. Bela, ma'am, for making us a part of this beautiful symbiosis. And it is really indeed a very, very learning process. Like it is a core of ultrasonography for obstetrician. The topics have been very beautiful. It is my privilege to be introducing the very beautiful speaker of today, Dr. Priya Deshpande. Ma'am is fellow. She has a fellowship in fetal medicine from Bangalore Fetal Medicine Center. She is trainer in fetal neurology by Professor Malinger. She is pursuing post-graduation in fetal cardiology. She is a fetal medicine specialist from Motherhood Hospital, Khargar, Surat Hospital, Chembur, Sri Sai Siddhi Diagnostic Center, Nerul. She is treasurer of the Association of Fetal Medicine Consultation, Maharashtra, West Zone Coordinator, Foxy Imaging Science Committee, Faculty of Fetal and Gynec Imaging. She's Executive Committee member of Society of Fetal Medicine of Mumbai chapter, and she is Mandakini Parihar Awardee for Best Clinical Case Presentation 2020. Thank you very much once again. And now I'll hand over to Dr. Priya Deshpande for her talk.
Thank you, madam, for the kind introduction. Can I share my screen? Screen visible?
Not yet, not yet.
Not yet.
Yeah,
now it's there.
Okay. Okay, so first of all, I want to thank Bhopal Obiju Society and Foxy, of course, this being my privilege and honor to be a part of this symbiosis today. And I've got the opportunity of being in Bhopal twice before. And I really like the enthusiasm of people in Bhopal, and we've received warm welcome there. So yes, of course, the two topics which are covered today by our own lovely Dr. Bela ma'am, and no words can really describe her multifaceted talent. And the Dopplers and obstetrics, of course, so beautifully and concisely covered. And of course, screening for preeclampsia. But now I come to a little bit more on the ultrasound part of it. So I was thinking that we are going to talk about anomaly scan in the first trimester because that's what everyone asks us to talk about. But then Dr. Bela ma'am, she said, no, we are going to talk about the proper anomaly scan because we need to, that's what obstetricians want. And we want the obstetricians to be very well versed with this if they are scanning or if they are not scanning as well. So that we are updated on terms as what we should expect in today's era in an anomaly scan. So gone are the days of 90s and 2000s when we should just get the FHR and a little bit of biometry, BPD, FL, and that's all. We've come to a level where we can see almost all the structures in detail, and I'll show you all that, and I'll try to show all of it as much as possible. Okay, so anomaly scan, the synonyms, multiple names. Mid-trimester anomaly scan, the MTAS, or TIFA, targeted imaging for fetal anomalies. Genetic sonogram, level 2 scan. But all said in one, it's the same thing. It's the same anomaly scan. Now, what is the scope of this anomaly scan? First of all, of course, checking the fetal anatomy and ruling out major abnormalities. Secondly, screening for PE and FGR, as we've seen by uterine artery Doppler. Then screen for preterm labor as well by checking the cervical length and assessing the cervical status. After doing all this, this is not the point where we stop. We also go on and look for soft markers and screen for the soft markers, which will give us an idea of the risk for chromosomal abnormalities. Then we should not forget placenta and amniotic fluid, because some problems with the placenta can be life-threatening and all the obstetricians know its implications. Hence, we have to train our mind and eyes to look at the placenta and rule out invasive placentas in particular. And of course, biometry, that was the basics. So our main objective is to diagnose and to diagnose all the abnormalities accurately. And we all are trying to deliver optimized antenatal care with best possible outcomes for mother and the fetus. Now, this is something which we follow, the ISOC practice guidelines, and these have been recently updated in 2022. So what do these guidelines say? Now, who should have this anomaly scan? All women. So if a first trimester scan is missed, today we must say that it's not acceptable, but if it is missed, it's still okay. But an anomaly scan is a must for all the women or for every pregnant woman. Now, when should we do it? 18 to 22 weeks. Initially, we used to do it at 18, 19 weeks because we had that strict cutoff of 20 weeks and then we can't go ahead if we have some problem. But now with the flexibility in the MTP Act, we can sometimes extend our study till 21 to 22 weeks because some structures, in particular the fetal heart, is much more clearly visible at this time. Now, according to the guidelines, what all should we see? Of course, the biometry, that's the basic, the BPD, HC, AC, FL, to see how the baby is growing. And whenever we are taking any parameter, we have to plot it and jot it down on a graph so that we know how the baby is growing according to the gestation. And apart from this, we are going to do anatomical survey. So let's see. Now, this is a list which is given in the paper. And it's the same, that we go from top to toe for the fetus. And also don't forget the amniotic fluid, the placenta, the cervix, and the uterine artery Dopplers. Now, there is something called as 20+2 planes, and it's just easy to remember this because once we go step by step and once this is imprinted in our minds, it's hard to miss something major. So what is 20 and what is 2? 20 are the number of images which we should ideally take, at least minimum, and 2 are the planes or the sweeps in which we would want to sweep the baby. Now, sweep 1 is longitudinal from the head, body. That is just to see how the baby is oriented. And then these are the 20 planes coming from the head, spine, thorax, abdomen, pelvis, extremities, upper limbs, lower limbs, face. And then there is another sweep, which is a transverse sweep. That is from the body to the sacrum and with one vertebra at a time. Now, talking like this theoretically really doesn't make sense. So I'll just show you how we do it. And when we saw that anybody who is following this 20+2 plane approach, at least 50 abnormal fetal appearances or 50 fetal anomalies could be easily ruled out. Hence, following it on a daily basis systematically is useful and advisable. So the initial sweep, what do we see? How is the fetus oriented? What is the lie? Is it longitudinal? Is it transverse? Is it oblique? The fetal presentation, the FHR, situs, and placental position. Of course, subjective assessment of the amniotic fluid. I'll just show you. This is a small clip. So the fetal stomach, starting from the fetal head. Now I'm going to imagine myself as a baby. So the upper portion is the left side of the fetus. And just scroll down. And what I'm going to see is, if I see here, this is the left side, the fetal stomach, fetal heart, both are on the left side of the fetus. That means that this is a normal situs. So this is the easiest way in which anybody who is scanning can make out whether the situs of the fetus is normal or abnormal. Let's see these few clips. Now that's the fetus line and we can see it entirely. So this is the first sweep. This is kind of a mid-sag sweep. Here the fetus is looking up. And on the opposite side, I just nudged the fetus and the fetus turned, and that's the sweep of mid-sag showing the fetal spine in its entirety. Now this is the same sweep which we took for the fetal situs, coming from top to bottom. And just to see whether the structures which are supposed to be on the left side, that is the fetal heart and stomach, are lying on the left side and ascertaining the normal situs of the fetus. And then switch on the color Doppler on the fetal heart and we can see beautifully the 4 chambers, the 2 red jets and the V-shaped blue jets rules out major abnormalities of the fetal heart. Now, just to show you when we do it, how and what do we see? This is the biometry. Now, these are the standard planes. This is transventricular plane, transcerebellar plane. Then this is the abdominal circumference, the humerus, and the FL. Basic biometry. But when we advance beyond basic biometry, that's how we see the transventricular plane, transcerebellar plane. That's the fetal heart, which we saw, along with the color Doppler, ascertaining both are on the left side. Then go down and see this 3 lines. That is the umbilical cord inserting in the abdomen of the fetus. This color shows that it's actually an abdominal cord. And then if we scroll a little down, we can see this umbilical cord dividing. That's the 2 umbilical arteries, and this black space, that's the fetal bladder. Now this is the fetal spine. If we go in a sagittal sweep, we can see each and every vertebra. More importantly, we have to see this intact skin, which is covering the fetal spine, because that is where we are going to exclude the open neural tube defects and the bulges which will be coming out. Now we just come at right angle and sweep here. We see this is the coronal view of the fetal spine. We can beautifully start seeing the ribs also here. And we switch on the Doppler and see the 2 renal arteries and the 2 kidneys as well in 2D. See these 2 kidneys on each side with the renal pelvises. And if we have to measure the renal pelvises, we do it in this fashion when the spine is up. Now coming to the extremities, these are the 2 legs side by side. We should ideally see all 3 segments, the thigh, knee, leg, foot, and this angles, because the foot has to be at the right angle. If it's not so, then on the spot, we are going to diagnose something as a CTV. And then when we go down, we see like this, the 2 feet with the toes and heel. Now that's the hand, all 5 fingers when the open hands, but we are not always lucky to get the open fingers of the fetus. And when we don't get it, we just nudge the fetus or tap it a bit so that the fetus opens its hand and it waves at us. So this is how we see the fetal hand. And that's the umbilical cord there. We can see the coiling too. Sometimes if it's a hypercoiled placenta, we are going to see a lot more of this blue and red than what we are normally seeing. Now to see the fetal face, this is the way we are going to see the fetal face in the mid-sag section and measure the nasal bone. And then we have to turn our probe and see these 2 fetal orbits, the eyes. These 2 dots are the lenses. Coming down, this is the palate, the hard palate. And when we sweep, we are going to see beautifully the upper lip, the lower lip, the chin, and the nose. We can see the nostrils too. Now, these are additional views of the fetal heart. That's the arch, the ductal arch, the aortic arch. These are the SVC, IVC. And if we switch on the color, we can see beautifully all the circulation happening. And this bright spot is the ductus venosus. So that completes our anomaly scan. Of course, but nowadays, with the improved technology, 3D and 4D is a new kid in the block. And of course, even the couple are so excited to see something like this because it is easily that they can relate to. Our 2D images are a little boring for them. Also, look at these fingers so beautifully seen, both the hands. These are this. We can actually study each and every vertebra, all the ribs. That's a cute face, 3D rendered face. I've just rendered this heart for you. That's actually a longitudinal arch of the heart. See how the valves are opening, closing. That's the aorta. That's the ductal arch coming from there. The fingers again on the face. That's the four-chambered fetal heart. The valves opening, closing, the four chambers, ventricles, atria, foramen ovale. And that's the brain, which we can render now. So we've done all this. We have estimated the fetal weight as well, and we've plotted it on the graph. Okay, so that's how we get an idea of how the fetus is growing at that gestational age. Now, let's see what planes are required system-wise. So from top, if we are going to see the fetal head, one plane is transventricular plane. So these are the ventricles. And this is where we measure the ventricles as well. Because if they are more than 10 millimeter, then it is ventriculomegaly. That's transthalamic plane. This is transcerebellar. The dumbbell-shaped cerebellum is seen. And when we go centrally or mid-sagittally, we can see this corpus callosum and vermis. Now, once we've seen this, what do we just notice? The biometry, of course, the shape, it has to be oval. There should be no protrusions. The contour is regular. The density, because sometimes in osteogenesis imperfecta, or if there is some skeletal dysplasia, the mineralization of this bone is going to be inadequate. The midline, so sometimes it is unequal division. All that has to be noted down. And okay, so the structures of the brain. So that's about the head and brain. This is a normal section of the fetal head. Okay, the same. We have to note this rectangular box here, which is the CSP. If this is absent, then that again indicates many abnormalities of the fetal brain, like corpus callosal agenesis and the dumbbell-shaped cerebellum when we scroll down in the posterior fossa. So that's about the head and brain. Additionally, we can take this section if we want to see a few other structures. Okay, so that is a detailed neurosonogram, but I am not going to go in details there. I will just show you, if we don't see these abnormalities, see these normal structures, how are we going to diagnose or easily rule out abnormalities? Look at these frog-like eyes. So that's anencephaly at 20 weeks. Here, clearly, this is where this ventricle is enlarged. So it's ventriculomegaly. Here, the contour, it's not continuous. There's something protruding out. So it's encephalocele. And the cerebellum here looks like a banana. It's no more the dumbbell-shaped cerebellum. And this is indicative of an open neural tube defect. I've just put in a few of the images of anencephaly, and these are 3D rendering of the same. Here we can see only the face, the base of the skull, and the upper portion of the skull are completely absent. Okay, so this was again acrania, which has led to anencephaly, which had come late in the second trimester. Now coming to this. So we've seen this protrusion, that's encephalocele. It was posterior, that's why it was occipital encephalocele. Here we can see gross dilatation of the lateral ventricles. It's all, the brain is filled with water instead of the brain matter. So this was severe ventriculomegaly, or also called as hydranencephaly. Now we know that these are not compatible with life. Hence, diagnosing all this will help the couple take a decision of termination and will justify the same too. Now, again, the spine, I was just trying to show. Many a times we see the spine this way, like the middle picture, but we should ideally tap the baby and try to take a little bit of distance here so that we see the skin covering the spine in continuity and in entirety. Now, this is a normal coronal view of the spine. We see this projection beyond the iliac bones. And this was sacral agenesis, which all obstetricians know that it happens in an uncontrolled diabetes because the lower portion of the sacrum didn't develop. So this image, spot diagnosis, that if we don't see this V shape, it's sacral agenesis. Now, this scroll through, we see 3 dots of the spine. We are going to go from top to bottom. And that will also give us an idea if something is protruding out in cases of open spina bifida or neural tube defects. Just a 3D rendered image. Wherever we have doubt of development of vertebra and spine, we can render it and actually count each and every vertebra and diagnose abnormalities there. Now, this is again a spot diagnosis where we can see this thing protruding at the lower end of the fetal spine. So it was an open neural tube defect and the cerebellum was pulled down, giving it a banana type of appearance. I've just rendered these images in 3D and we could actually see this defect and the opening here with the protrusion of the spine and the meninges out there. So rendering really helps even the couple to understand what's happening. Now the kidneys, whenever we're trying to see the kidneys, we should supplement it with the color Doppler because the renal arteries do follow the kidneys. And whenever we're going to measure the kidneys, we must measure in this way when the spine is up. Okay, so not going much more in detail, just to show you in this clip how the kidneys are seen clearly like two bean-shaped structures. And this hypoechoic structure, that's the suprarenal or adrenal glands. Okay, now this is dilated renal pelvises. But if we measure the renal pelvises in this fashion, we are going to over-measure them. Hence, we should always make a point that we are going to measure it in this axial section. Now, this was an interesting case of horseshoe kidney. So the bean-shaped structures which I showed are not seen here. It's a continuous U-shaped structure seen here. And I just switched on the color Doppler. The renal artery is also taken down. It's pulled down because of the shape of the kidney like that. So this was a horseshoe kidney. And we did chromosomal analysis and found some abnormality there too. Hence, looking at, if we don't have the normal expected image, then definitely it's a pointer for us to go and look at that particular organ in detail so that we don't miss out on these abnormalities. Now coming to the fetal phase, this is a beautiful mid-sat section of fetal phase. Sometimes the fetus is like this. And if we consider and measure the fetus in this position, we are going to be inaccurate. Why? Because this is not a mid-sat section. Hence, we have to wait for the baby to jump a bit and we should see this chin out there properly. Okay, with a little bit of fluid behind or below the chin. Now, I was lucky enough to get the fetus open its eyes. Generally, the fetus doesn't open its eyes in the womb and we know that. So this was the closed eye. Normally, we get a picture like this, but in a blink, the fetus opened its eyes and I could get this beautiful image and the couple were so happy to see these open eyes in the fetal face in the rendered face. Now, this is typically how a flat face is seen this way. And a rendering, of course, showed us that kind of beautiful, nice 3D image we can never get in a flat face. And we know the implications of flat face being a part of skeletal dysplasia as well. Now, this image definitely is, it's clearly a diagnosis of a small chin or a regressed chin. So this was a micro or a retrochmatia. Now, that's the palate. These are the two orbits and those white dots are lenses. See, that's the maxilla. That was the tongue and the mandible. So orbits go down the maxilla. This was the tongue. Just going down, that's the tongue and that's the mandible. So a scroll through can give us an idea of the palate as well. If we don't see this, let's see what are we going to diagnose. Something like this. There. So this was a gap. This was a gap in the palate here. And that's why the lip was protruding. And when I just 3D rendered it, could show this gap easily. So for a couple as well, when we tell them that there is a gap in the lip and the maxilla, they won't understand. But if we just render the image and show it to them, they can immediately relate to it. Oh, there is a gap here. The lip is not formed. Hence, they can think about it, whether they want to continue with such kind of pregnancy and have a surgery done later on or not. Now here, the orbits are not looking like what we saw there. This orbit looks so small. So this was a case of microphthalmia. So the eyes of the fetus, they were not, even in the 3D we can see here. So this was a case of microphthalmia. Hence, just a normal ideal plane. If we don't get a normal ideal plane, it is definitely going a point or pointing out to a diagnosis of something like something major and sinistrous as a microphthalmia. Now, this image gives us a clear picture of the same. This is Cyclops. So the two orbits, as we've been seeing, they have to be at a distance. But in this case, there was no distance. And in fact, there was a proboscis too. So this was a case of Cyclops with proboscis, which turned out to be trisomy 18. Okay, now these are the ears, or I would like to call pinna. Okay, because the external ear is the only thing which we see. So 1 and 2, we scroll from one side to other and look at the external ears too. Because there can be so many abnormalities with the fetal pinna. There can be tags, small ears, which can be pointers towards genetic syndromes. Now that's a sweep which shows us nice continuity of the upper and the lower lip and chin. And if we find there is discontinuity of the lips, then of course it's a pointer of the cleft lip and palate as well. So coming down to the important section of thorax, as we've seen here, this we can see is the diaphragm. Okay, a clear demarcation. So this upper portion is the thorax, lower portion is the abdomen. And when anything is protruding out from abdomen in the thorax, it's the diaphragmatic hernia. So that becomes a spot diagnosis for us. Here, just to show you, this was a case where stomach and the fetal heart were both seen in the same section. So, of course, it was a left-sided CDH and it was a major one. And to show you the actual breach in the diaphragm, this is how the stomach was coming out from the abdominal cavity into the thoracic cavity and causing the or pushing the heart to the other side. So, an easy diagnosis once we have done our review systematically. Now, in the four-chamber view of the heart, this is how we see the left ventricle, the right ventricle, the valves, the mitral and tricuspid valves, the foramen ovale. We see the pulmonary veins, the atrium, and the chambers. So much to be seen in one four-chamber view. Coming down the abdomen. So that's the ideal view in which now what should we have? This one on one side, there'll be spine. On both the sides, there'll be only single rib. This is the fetal stomach bubble, and that's the umbilical vein seen. So this is ideally how we should measure the abdominal circumference. If we take a section like this, which is oblique, then going to be multiple, and we won't be seeing that umbilical vein properly, and so on. Hence, we have to stick to these guidelines. And we should not forget to see this gallbladder, because absence of gallbladder can be a part of a lethal abnormality. Now, this was a recent case, nothing significant, but I just saw the sludge in the fetal stomach bubble. We can see that white dots. So I did not scare the patient, but I just wanted to show all the obstetricians here that sometimes we see this, maybe the fetus has swallowed some blood which had, or maybe there was a first trimester bleeding which it had swallowed. But the fetus pregnancy is now 30 weeks and everything is fine. The baby is growing well. There's no problem. Now the cord insertion, which I had shown, and if we go down, we can even see the the urinary bladder. And why it is important to see this, because we can diagnose a single umbilical artery there or dilated urinary bladder like this. So this was a case of dilated urinary bladder as well as dilated so obstruction to the urinary outflow. And hence, when we put the color, we can make out that this is a urinary bladder and no other structure there. Hence, that's the use of the color Doppler and how it can assist in our diagnosis. Now, as we see here, this is the normal insertion of the umbilical cord. And if we don't see this kind of normal insertion and there's something protruding out, then it is exomphalos. Okay, so just a minute. So this was a case of exomphalos. The intestines were protruding out in the amniotic fluid. Now the extremities, as I have specified, we should see all three segments and at right angles. If we don't see them like this, then we can do a spot diagnosis of CTEV, that is talipes. And I'll show you how it looks. These are the hands and the feet, which I've shown before. That's how a talipes looks. So the ankle, the calf, and the foot, they are seen in the same plane, which we should not normally see. We should always see them at right angles. If we see the entire foot in the same plane, then that's spot diagnosis of talipes. This was a different kind of talipes. It was completely folded. I just rendered it and we can see it, how it was completely folded. So this, if we show the couple, they'll understand that's very difficult to correct this kind of abnormality as opposed to mild talipes. And this is an extra toe there. So this is a polydactyly. Now, polydactyly, as we know, our famous Hrithik Roshan also has, and hence the couple will understand that it's not a lethal abnormality and we can continue this kind of pregnancy. Coming to the amniotic fluid. When we are estimating the amniotic fluid, we have to take all the pockets, add them up, and then get an amniotic fluid index. And we always plot them on the graph like this. This red dot shows us that it is within the normal range. Sometimes I've seen something like this, and they've been referred to me saying that this is a band. And of course, amniotic band has a very bad outcome. But just to show you, this is just a normal sheet which is going through the amniotic cavity, and there was no fetal part attached to it. So we term it as amniotic sheet. It is free floating generally in one corner of the amniotic cavity from anterior to posterior, and it has no vessels. There is no fetal part connected, and it is absolutely benign and has a very good outcome. Hence, we should not scare the patients where they need not be. This is placenta. We have to see whether it's on anterior wall, posterior wall, and we have to note this subchorionic hypo look at the echogenicity. The echogenicity is less. So that zone is important. This means that the placenta is normally inserted and it's not there is no accreta or increta or percreta. And we all know how disastrous it can be if it is missed. The cervical length ideally should be checked by TVS, internal os, external os, and a straight line to measure it. Of course, we should not miss the fetal movements because sometimes fetus can have myopathies. And if we don't see the fetus moving at least one flexion extension, then we should mark it down and call the fetus again to check if it's moving back. Now, we've seen the anomalies, but there are something called as soft markers. I'm not going to go in details, but we have to look for them as well. And why are we going to look at them? Because these soft markers are not abnormalities, but they increase the risk for chromosomal problems. And hence, we have to calculate the risk and then report it and counsel the couple accordingly. If need be, we have to then ask them to go for amniocentesis and karyotype or microarray. Okay, so that's the way we are going to assess the risk, but I'm not going in details in this. We can have the session some other day. And this is just a protocol in which we are supposed to report. Now, this, if we don't have a software through which we are reporting, we can use this reporting format which is given by ISOOG and report all the organs which we are supposed to see. And we have to jot down all measurements and report it in this fashion so that we are medico-legally correct. Okay, so ultrasound is the main diagnostic tool in prenatal detection of abnormalities. It allows examination of not only external, but the internal anatomy of the fetuses. And not only the major defects, but also subtle markers can be detected. Now, I will just take one more minute that detecting an abnormality just doesn't end the story. In fact, the story starts here. Because if we are going to detect an abnormality and terminate the pregnancy, we'll all be terminators of pregnancy, which we all obstetricians are not. We just want the well-being of our fetuses and mothers. Hence, the role or the pivotal role of counseling comes in. And all these are the common questions which come to the couple's mind. Oh my God, why me? What did I do? What is my fault? The pregnant lady just starts crying and they are all worried that what do we do next? But as a sonologist and an obstetrician, we have to understand the psychological distress and put forth all the knowledge that we have so that they can take an informed, wise decision. Okay, so we of course detect abnormality, we counsel them. The couple are anxious, they do Google Baba is the greatest enemy of us. And of course, doctor shopping, which we know that we get a call from our own friend saying, अरे वो patient तो मेरे पास आ गई, वो बोल रहे हैं आपने बोल दिया सब abnormal है, आप हम terminate कर देंगे. So this is a common scenario and we know that this happens in today's world. Hence, we should all work as a team. A fetal medicine expert, of course, or a sonologist, along with obstetrician, along with geneticist, and along the surgeon or the physician if there is some kind of abnormalities. only if we work together, we are going to complete the picture. And the primary aim is to educate the parents about that anomaly. Also, to tell them whether this is an isolated abnormality or it is a multiple defects which are seen, and if there can be a genetic association. Also, whether the abnormality is lethal or it's non-lethal. Lethal, we don't have much to do. We just have to apply or go for termination. If it is non-lethal, is it treatable? Many of the abnormalities today are treatable. We know that. In that case, we can continue. We can do fetal therapy as well. Like we do fetal transfusions, we do fetal lasers. All of that can be immediate therapy, or it can be later on also. This can all the therapy like for talipes or for clefts in the lips and palate, they can all be corrected later on after delivery. Okay, and if it is lethal, then of course termination. That's the only option. And that's how our story gets completed. The success lies in giving our best efforts, and if the efforts are sincere and intentions are noble, even missing the mark is not a failure. Thank you so much for your patient listening.
Such a nice talk, ma'am. The talk was it was beautiful. I would really appreciate the pictures you have got into this talk. They were originally your pictures, ma'am. I'd like to know about it.
Yes.
Of course, mine.
And that they were in encyclopedia of second trimester anomaly scan. This many pictures in such a beautiful way you presented was really good. And I am very sure that all the obstetricians out here would definitely start doing their own anomaly scans for their patients from tomorrow. It seems so easy because anomaly scan is usually, whoever is doing sonography usually avoid doing anomaly scan. They usually send at least for the fifth month. That is what I used to do. For rest of the sonographies I do, but for the anomaly scan I used to send the patient to the sonologist. Lekin I'll definitely try doing it myself from tomorrow itself, because that 20+2 plane and the ease with you explained everything was really beautiful. Thank you very much.
Thank you so much, ma'am. Coming from a senior obstetrician like you is really, it's humbling, and
it was really
I think
beautiful.
it's worth my efforts. And of
Dr.
course, if we go
Single and
systematically,
very systematically, very orchestra kind of a thing. It was very well symmetrized. Thank you very much.
Dr.
Thank you so
Priya,
much.
I must compliment you for the beautiful lecture. I can't decide whether the talk was better or the slides were better or the images were better. Everything was like perfect. Like Sunita ma'am said, like in orchestration. Very beautiful.
Yeah.
Thank you so much, ma'am. Thank you.
You
Thank
have
you for
made
the
our job for the panel very easy, because today the panel is going to be, I have not called it panel discussion, it's a conversation. So we will first know from the panelists how much ultrasound they are doing, because all of them are busy practicing obstetricians. How much is their interest in the field? How far do they want to go? What are the problems like they are facing? Like Sunita Vadvani madam just said that she is not confident about anomaly scan.
Yes.
So most of our stalwarts in fetal medicine are actually gynecologists. So Bela ma'am, Dr. Priya. So basically, when you are a practicing gynecologist and you pursue sonography, it's a different passion altogether, because you are going from beginning to end. So congratulations, Dr. Priya. And it was lovely having you here. And thank you, Bela ma'am, for
thank you, madam.
suggesting the names of our speakers. It was a very great show. Thank you.
Thank you so much, Dr. Priya, for the wonderful talk and the wonderful collection of your images and everything. With this,
Thank you, ma'am.
this brings to the end of all the talks, and we move on to the panel discussion next. For this, I'd like to invite my moderator, Dr. Purnima, to take over. Over to Purnima.
Yes. Yes. Thank you, ma'am. Can we please show the title slide of panel discussion? Yes, thank you, ma'am. So the title of our panel discussion is Interesting Obstetric Ultrasonography Cases, Case-Based Discussion. The moderator of this panel discussion are Dr. Monica Singh, ma'am, and Dr. Anshu Base, ma'am. And Dr. Monica Singh, ma'am, is the Honorary Secretary MP Chapter Hisar. She is Vice President Bhopal Ops and Gynae Society. Ma'am is Vice President.
You can skip my
Bhopal.
CV, just introduce Anshu. I've been
Ma'am, you never let me say your slide, never let me speak your slide.
Doesn't matter.
Thank you, ma'am. Next moderator is Dr. Anshu Base. Ma'am is Junior Consultant Obstetrics and Gynecology at Akash Hospital and Diagnostic Center, Indore. Ma'am has published various papers in national and international journals and also has co-authored the book Ultrasound for Beginners. She has co-authored chapters in Foxy publication and has also presented various papers and poster. She has been awarded second prize in paper presentation in MOX 2020 and awarded first prize in quiz on genetics in INHS Ashwini. She is also an active member of Foxy Young Talent Committee, and her area of interest are ultrasound and endoscopy. We welcome you, madam. Thank you for joining us today. And our panelists are Dr. Aarti Darga ma'am. Ma'am is consultant at Vijay Nursing Home. She is an alumna of Baroda Medical College, and she has been trained in ultrasound and laparoscopy and having area of interest in recurrent pregnancy loss, infertility, and high-risk pregnancy. We welcome you, madam. Thank you for joining us. Our next panelist is Dr. Aditi Rathod, ma'am. Ma'am has done certificate course in hospital management and is consultant Rathod Nursing Home, Jaora. She is secretary.
नीचे खींचो पेट में.
Monica, ma'am, you are not muted.
Sorry, dear. Sorry.
Dr. Aditi, ma'am is secretary Ratlam Ops and Gynae Society. I welcome you, madam. Our next panelist is Dr. G.R. Radha Lakshmi ma'am. Ma'am is an alumni of Tirunelveli Medical College. She has done embryology course from Chennai Veterinary College and Asia Pacific School of Embryology under Dr. Kamini Rao ma'am, and she is director of Prasanna IVF Center at Villiputtur, Tamil Nadu. We welcome you, madam. Thank you for joining us. Our next panelist is Dr. Manisha Jain ma'am. Ma'am is Treasurer Bhopal Ops and Gynae Society and Professor Ops and Gynae People Medical College and Research Center. Thank you, ma'am. Our next panelist is Dr. Neha Saraf ma'am. Ma'am is ex-secretary Ratlam Ops and Gynae Society. She's consultant Ankur Hospital Ratlam. She's an obstetrician and laparoscopy surgeon. Thank you for joining us today, ma'am. Our next panelist is Dr. Nidhi Bajaj. She's director at Spersh Multi-Specialty Hospital, Katni. Ma'am is secretary Katni Ops and Gynae Society, and she's an alumni of GMC Nagpur and also KEM Mumbai. Ma'am has done fellowship in reproductive medicine, has various publications, and is member of various professional bodies, and also active in various social activities, and has been awarded as Young Talent Award at West Zone UA Foxy, October 2022. Thank you, ma'am, for joining us today. Our next panelist is Dr. Ruchi Saxena. Ma'am is practicing Ops and Gynae in Narmadapuram. She's medical superintendent SMH Hospital, Narmadapuram, having experience of more than 25 years. Ma'am is present secretary Ops and Gynae Society, Narmadapuram, and life member of IMN Foxy, and doing various social activities as well. Thank you for joining us today, ma'am. Our next panelist is Dr. Rupali Maheshwari, ma'am. She's an alumna of Grand Medical College, Mumbai. Ma'am is associate professor and Foxy trained ultrasonographer. She's consultant at Pushpa Mission Hospital, having a special interest in infertility, recurrent abortion, high risk pregnancies, and having experience of more than 18 years. We welcome you, madam, on this platform today. Thank you all panelists for joining us today. Next slide. So I would like to hand over this session to our moderator.
Thank you, Dr. Purnima. I'm sorry for the disturbance. My dog was wearing a sweater, so I was worried. Thank you. So let me share my screen and welcome to my beautiful panelists. And like I mentioned, this is going to be a conversation. So we will have a lot of discussion, Anshu and myself with you all. And we'll just have a talk as to how to improve our practice of obstetric ultrasound. So at the start of the panel discussion, I would just like to have a word from all my panelists as to how much of sonography you are doing. What is your confidence level in ultrasound? What is your target for the next 2 years or 3 years or 5 years down the line? Because all of you are different ages. How much you want to excel in this field? How much time of your practice do you want to give to ultrasound? What is the type of machine you want to invest? You want to go for very high-end machine, or you would like to do basic? So this, all the panelists can please share with me, so that the number of questions we have, that way we are comfortable. Yeah, you can just like share.
Hello, good evening, ma'am. Good evening, Monica, ma'am. Right now, I am having Volusion P8 with me. I am practicing in a Katni. It's a kind of a rural district place, kind of a thing. It's been almost since 2017. I'm doing my independent ultrasounds, including NT-NB scans and all. But for anomaly scans, I am sending it to the radiologist. Doppler, I'm doing on my own.
Okay. Dr. Aditi?
Good evening, ma'am. First of all, thanks a
Myself
lot.
also same.
Yeah. Yeah, please, all of you can introduce yourself.
Yeah, thank you for having me here, ma'am. I am practicing in Javra, very small place. So I have a Samsung Sonoace R7. I don't have a 3D probe, I have a 2D probe. So I do my basic scans, but for NT-NB as well as for target scan and color Dopplers in the 9th month, third trimester, I refer to a radiologist mainly for medico-legal protection. So my confidence about my scans is that if I can distinguish normal from abnormal usually.
Yes.
If I find something is abnormal, I on bird's eye also, so I can tell the patient ki you might have a problem and you have to go for a second scan. So 99% of the times I'm right.
Yeah.
Otherwise,
I think that is the crux of whole diagnosis. You should know how to recognize normal. I think that my mentors who taught me ultrasound, and I think Anshu will agree, first you learn to recognize normal. And once you're confident about recognizing, you have seen so many normals, you keep doing, keep practicing. Then ultimately, when you see something abnormal, you can, make a note of it and then take help of your friend, colleague, senior, whoever, a fetal medicine colleague, as to whether your doubt or your hunch was correct. Am I right, Anshu? Anshu, you're muted, dear.
90% of your scans are going to be normal. The 10% that are abnormal, you should be able to recognize. That only comes if you have enough volume of work and you are practicing on enough patients to see normal scans. So the first is always to identify normal. Then we should aim higher to identify what the abnormality is. So that's how we go stepwise in ultrasound or anything for that.
Dr. Neha, Dr. Radha, Dr. Rupali, please give your inputs.
Good evening, everyone. I'm
Yes.
Practicing in Ratlam. It's a small place. We have to do our scans on our own because we don't have too many radiologists over here. So basic scans, NT-NB, and all the trimester fetal growth scans I'm doing on my own. On an average, I'm doing 10 to 15 OBGYN scans daily. But for the anomaly scans, I'm referring my patients to a radiologist. Same for the medical, legal, and the documentation purpose.
Okay, Dr. Rupali, Dr. Radha.
I'm practicing in Ujjain, and I'm doing my scans myself, but not NT and anomaly and Doppler studies. First of the reason is that I'll need a little bit of training. I think to excel means to do these scans better, and also sometimes it is really these scans require time. So I think and sometimes when we are very busy in a OPD, we might not give justified time to to these scans, because NT anomaly scans do require time and patience from the obstetrician. Obstetrician is sometimes very busy. He is having many fronts open. But I really love.
You're right. If it is a very busy practice, a very busy obstetrician who has to go to labor room, who has to do, in between gynec procedure, or maybe do infertility patients, then she will have less time. She or he will have less time for scanning. That's right. And sometimes for a proper NT, you may take up to 20 minutes, 30 minutes also, even more.
What I feel is by doing scans that at least I'm able to identify patients who are having abnormality. So I refer to radiologist if there is some abnormality.
What about Dr. Radha Lakshmi?
Yeah, I'm practicing in a small town in Tamil Nadu, madam. I'm practicing ultrasound since 1996 from a basic machine, and I upgraded to Viprology 400 Pro, and then to Voluson P8. So I can do all basic scans. As everybody said, I used to refer for anomaly scan for second opinion. A bit of anomalies I can detect.
Okay, great. Is there anybody remaining or everybody has given their inputs, Dr. Manisha?
Ma'am, Dr. Aarti ma'am here.
Yeah, please.
Yeah, for myself also similarly only. For anomaly scan, I refer outside. Otherwise, all the other scans I do myself, ma'am. Yeah.
So now we are definitely all, after the beautiful lectures, we all want to do Doppler like Bela ma'am. We want to do target scan like Priya ma'am. And we want to do accurate pre-eclampsia prediction like Dr. Smita, right? So how do we achieve? It's not difficult. And see, I'm not perfect. Anshu might be progressing towards ultrasound, but basically I am an ART person. And very early on in my practice, I started practicing in 1997. In 97 till 2005, I did obstetric as well as infertility practice, and I started dabbling in ultrasound. In fact, I bought a very nice machine with TV probe in 1999, the year my daughter was born, and I got TVS in gynec pathologies as my thesis topic. So, in my post graduation, that fueled my interest. But gradually, the interest grew because I reduced my obstetric practice significantly so that I got more and more time for scan. And of course, I invested in good machines continuously. So today it's going to be a dialogue, a conversation about simple obstetric scanning and how we can improve our practice. Welcome to all panelists. And we start with very simple things, and we basically start with early pregnancy. Okay. So, according to you, now you have probes. You all of you are machine owners, and you have got the convex probe, and you have got the TVTR probe. When it's an early pregnancy, let us talk about pregnancy. Just overdue patient with a small gestational sac to the end of first trimester. What is the ultrasound modality of choice in diagnosis and assessment of early pregnancy? Anybody can take the question.
Transvaginal sonography.
And why is it?
For better vision, better vision, and both ovaries,
as well.
Yes. Can somebody tell me what is just compare for me the frequency, resolution, and penetration of a convex probe vis-a-vis frequency, resolution, and penetration of a TV probe? Can somebody compare for me?
Convex probe is usually 3 to 5 megahertz, while TVS probes is 4 to 7 megahertz.
TVS probe is even like it can be 7, 8, up to 8.5, even 9 or 10
It
also.
can go to 9 also, yes.
Higher frequency, lesser penetration.
Yes, please continue. Who's speaking? Higher frequency, lesser penetration. I don't have the picture. Yeah. Please continue, Dr. Aditi. What you were saying about the frequency and penetration, how are they related?
So, ma'am, as the frequency increases, the penetration decreases, and the resolution increases, and the frequency of the transvaginal probes is still 11 megahertz these days.
Yeah. So it is actually this always you should remember, even if you are appearing for quizzes or basically you have in your mind your machine, higher the frequency,
lesser the penetration.
Lower is the penetration and better is the resolution. So you can see this TV probe over here. The TV probe is right near in the fornices, and the ultrasound waves are reaching all over the pelvic organs. So you are getting a beautiful image of the uterus, the bladder, the ovaries, the adnexa. But suppose the ovaries are far up in the abdominal cavity, like in Turner's, or they are adherent, or if the uterus is retroverted, then sometimes TV probe doesn't work very well because the rays cannot penetrate, the ultrasound waves not rays, the waves cannot penetrate up to the organ of interest. So that is the whole idea of a TV probe.
I would like to add that along with the TV probe, we should do a transabdominal scan also in early pregnancy.
Always. And why should every scan be preceded by a transabdominal scan? You can continue, Dr.
Yeah, ma'am, we have to see the location of the sac also. Sometimes scar ectopic is missed, and other things also. I had read a case where a ectopic kidney was there, and it was not caught on later on. Every early pregnancy scan should be done with a Bird's view transabdominal scan.
Yes, basically, transabdominal scan will give you a global or panoramic view of the whole pelvic cavity. So that is why you should always precede. In fact, in gynec pathologies also, this holds true for whether you are doing a gynec scan, an infertility scan, or an OB scan. Try to have a whole overview of the pelvis, and then you can proceed to your TBTR.
Also, one thing I'd like to mention that it is always we have to look at the adnexa in an early pregnancy scan. Sometimes I actually had one trainee who came to us. She said, "Ki I do a scan at 5 weeks to locate the pregnancy, just to rule out an ectopic, and then I do again a scan at 7 weeks to see if it's intrauterine or not." So I think that is absolutely not required. We should plan it that way that we see the entire pelvis during an early pregnancy scans. Also, sometimes if it is a retroverted uterus, what you can do is go behind the cervix and elevate the uterus with the probe. So that will help you see better. Or if the ovaries are lateral, we can put a hand on the patient's pelvis and ask the patient to press a little so they come closer to the probe. So that
Yes.
basic anatomy should be included in an early pregnancy scan.
Definitely, definitely. You're right, Anshu. So coming
Due
to the
to
next, yeah.
increased
Sometimes
expense of cesarean and all, madam. Nowadays, I see we could not even diagnose the early pregnancy in transvaginally. The transabdominal scan is better nowadays, the early pregnancy.
Yes, yes. No, no, it is totally up to you. As we'll come to the next question, you will see, madam, there are certain features of intrauterine pregnancy, early intrauterine pregnancy, which are very well appreciated with a transvaginal scan. So, who can tell me the definitive signs of an intrauterine pregnancy? What are the 3 things you should see to call it an intrauterine pregnancy? One second. You can just read the slide and tell me, and we'll discuss.
Definitely, we should see an intrauterine gestation sac.
Yolk sac is the
Yolk
most
sac,
important.
and then fetal hole.
Yeah, these 3 actually, these I've taken from guidelines, and this is very important that you should be. Yolk sac is not seen in any pseudogestational sac. It will be not seen in any hemorrhagic collection. Yolk sac is one feature which is definitive of an intrauterine pregnancy. Fetal pole also, and third is definitely a flickering cardiac activity. So gestational sac should not be taken as a definitive sign of intrauterine pregnancy because it could be a pseudo-gestational sac. And up to 20 to 30% of ectopic pregnancies give rise to an exact gestational sac-like structure within the endometrial cavity. So gestational sac per se, especially with transabdominal view, should not be taken as a definitive sign. So, when you are failing to identify a definitive intrauterine pregnancy, you have put the probe, the patient is 15 days overdue, a pregnancy test is positive, patient is empty bladder. You don't want to wait, you are wanting to see what is inside. So you do a gentle TVS, but you do not find a gestational sac. What do you do and what is the outcome likely to be? Can you tell me from your clinical practice?
It could be delayed HCG assay.
You can just answer one, like whoever's taken the question, the next person can answer. Yes, Radha ma'am?
It could be
Yes, we have to first look for adnexal region, madam. So when we do not find any intrauterine gestation sac, we should look for adnexa. And if there is an adnexal mass, then we can think of ectopic. Even otherwise, we are not seeing any definite mass in adnexa. We have to do the serum beta HCG level and serially monitor.
So there are 4 possible outcomes which can happen. Anshu, can you take when you fail to diagnose a definitive intrauterine pregnancy, what are the 4 possibilities that might be there clinically? Dr.
Number one, it is either a very early pregnancy that you have scanned the patient too early. That's why you're not seeing it. That is a normal finding.
And it may be mistaken dates.
Yes, exactly. Wrong dates, a very early pregnancy, or patient has long cycles and you have not calculated it correctly. So number one is that. Number two, it is either a delayed conception or that the pregnancy has miscarried. It is an incomplete or complete miscarriage. And number three is of course an ectopic. Number four is of course an ectopic gestation. So these are the four possibilities that you need to rule out, and sequentially, like ma'am said, see the adenexa, look for the corpus luteum as well. That is also sometimes a sign that we can pick up. And again, follow up and monitoring. That is the first thing. And also probe tenderness, I would like to mention. We actually once missed a case of an ectopic because we couldn't see the sac, but the patient was complaining of probe tenderness. And the week later, she presented to us with an adnexal mass. So
On the contrary, Anshu, I saw patient of an ectopic pregnancy, confirmed ectopic without any probe tenderness.
That is also.
I had done embryo transfer. So I was, that time this was around 2009 or 2010. So we used to transfer routinely 3 embryos. Remember, that was the time when, single or double embryo transfer was not there. So we used to get multiples, and this patient had no probe tenderness, nothing. I could see a single intrauterine gestational sac, but she turned out to be having a, heterotopic. And this mass in the adnexa was totally non-tender, but it developed it's sort of hemorrhagic collection. It became a sort of an organized collection. Luckily, it was a chronic ectopic, and we had to basically operate upon her because giving methotrexate was not an option with an intrauterine pregnancy, and luckily she continued with the intrauterine pregnancy till term. So all ectopics may not be tender. Sometimes you might just get a collection. And another patient I had of ectopic, she was only an ectopic, no intrauterine pregnancy. That patient, I called her again after 1 week after doing serial beta HCG. The ectopic pregnancy, I did not do any medical management, no surgical management. I just kept, watch on her. This patient disappeared for 10 days. When she came back, I scanned again, the ectopic had disappeared. So sometimes there are self-resolving ectopics also. So coming to the next slide. Anybody wants to add anything here?
Yeah, I just said the self is the only. I think there were many biochemical pregnancies, I think.
No, biochemical, तो Manisha तब होता है when you have,
it will
don't
not be
see any
seen.
stat, you just see a raised beta HCG.
No, with beta HCG.
Yeah, but here it was a well organized hemorrhagic collection in the adnexa with positive pregnancy test with beta HCG above 500, and the mass disappeared in 10 days. So what is the earliest sign of pregnancy on ultrasound? Coming back, now we have come to the conclusion that gestational sac might mislead you. So what is the earliest sign of pregnancy you get on ultrasound, and what is the intradecidual sign? Can somebody define intradecidual sign or just explain what it is? It is a very textbook sort of teaching, which the first sign you get. Where is the pregnancy?
The very first sign will be the thickened endometrium.
Yeah.
Then we'll have your corpus luteum on the either of the side of the ovary. 2. Third, the decidual sign is the sac will be surrounded by decidua from all the sides symmetrically. Unlike in an ectopic pregnancy where the decidual thickening may be unsymmetrical on upper and the lower edge.
So this intradecidual sign is basically the endometrium is totally undisturbed. You will just get a thickened endometrium of pregnancy, and inside there will be a small cyst-like structure which is hardly 2 to 2.5 to 3 millimeter. Remember, a true gestational sac starting with the intradecidual sign is always eccentric, and a pseudo-gestational sac will be exactly in the center because it is not a sac. And this intradecidual sign appears very early. Hardly the patient is, 5 or 6 days or 7 days overdue. And this will have a small echogenic ring around it, and it will be placed eccentrically. The endometrial cavity is totally undisturbed. So that is why it is called intradecidual sign. Okay. Now, you can confuse it with endometrial fluid collection, a decidual cyst, but I'll tell you how to differentiate it from this sort of a collection. So anybody has heard of the double decidual sac sign? What is it? It comes after the intradecidual sign. Double decidual sac sign. Has anybody read about it? Or probably Anshu, you would like to tell us about it?
It has got 2 ecogenic.
Yeah, Manisha?
It is because of decidual reaction, we see a 2 ring-like appearance. So that is double decidual sac sign.
So basically, double decidual sac sign
is the gestation sac.
Yeah, so basically this sac is supposed to have 2 echogenic rings. The outer one is the endometrium of pregnancy. This is the decidua. The inner one is chorion. And the decidua is more echogenic than the chorion. Now, this sign is debatable. Double decidual is there in the textbooks. You might sometimes appreciate it, you might not. But definitely, there are two rings which are, and the sac grows in size after the intradecidual sign. The problem of the pseudogestational sac is, which I told you earlier, is that it occurs in ectopic pregnancies also. And here you might think that the pseudogestational sac is the real gestational sac, whereas it is just fluid or blood from the tube because of the ectopic which is collected in the endometrial cavity. Now, how can you recognize it from true gestational sac? Can anybody tell me the difference between true gestational sac and pseudogestational sac?
It will be irregularly shaped
This will
and
be in the center.
It's
yes.
exactly in the center, right?
And development of the decidual ring.
Yeah. So this will have only one ring around it, which is the endometrium. There will be no chorionic tissue. There will be no chorion. And secondly, the ends of this pseudo-gestational sac are pulled at acute angles, forming a teardrop. Okay, because it is pseudo-gestational, it will not be perfectly rounded also. Now, what is the importance of yolk sac? Why are we so concerned about yolk sac, and when should we see it on transabdominal? When should we see it in TBS? What if it is large? What if it is small? What you can confuse it with? Can somebody just explain?
It has 100% positive predictive value in ruling out an ectopic pregnancy first of all.
You can rule out ectopic, but you can't rule out heterotopic.
No.
ART has changed everything, you know. So there are still places where 2 or 3 embryos are being transferred, and one embryo might just implant in an ectopic location. So basically, yolk sac is very important, and we are talking about just TVS right now. So when the mean sac diameter is about 10 mm, you should see, and the gestational age is about 5.5 weeks, you should visualize a yolk sac. And these are all the DDs. And what is a failed or anembryonic pregnancy? When the mean sac diameter is more than 25 mm. How to measure the mean sac diameter, I'm going to ask you. When the mean sac diameter is more than or equal to 25 mm without any fetal pole, without any yolk sac, then it is called an anembryonic pregnancy or a failed pregnancy. So this is all the importance of the yolk sac. So can somebody tell me, when does the yolk sac disappear? What is the
13 weeks, ma'am.
At what week?
At 13 weeks, when the the cavity fuses.
Yes. So how does the cavity fuse? When does the amnion form? At what weeks does the amnion form, and at what weeks does amnion fuse with the chorion?
Amnion is formed at 7 weeks.
Yes.
And it is between 12 to 13 weeks.
Right. So the amnion starts fusing with the chorion. It totally disappears at 14, 15 or 16 weeks, and that is the time the placenta takes over. And definitely all these yolk sacs, whether they are more than 6 mm, calcified, thick-walled, septated yolk sac, they are all abnormal. And there is a concept in multiple gestation that the number of yolk sacs is equal to the number of amnions. So in dichorionic diamniotic, you will see 2 yolk sacs. In monochorionic diamniotic, you'll also see 2 yolk sacs. Am I right, Anshu?
Yeah, 2
Yeah.
yolk.
Yes. So next, can somebody tell me what gives you the appearance of, have you seen the signet ring appearance, and what is the cause of the signet ring appearance? This is also very typical of early pregnancy.
The embryo at the edge of the yolk sac gives the appearance of the signet.
Yeah. This is very typical. The amnion is not there. This is a very typical condition. Can somebody explain? Whoever, because I'm talking too much, I think.
It is because of the appearance of the fetal pole, so that appears like a signet ring.
Yeah, here amnion has not formed and the embryo has formed. So the embryo is a small, small like a rice grain, which is attached to the yolk sac. And at the same time, the flickering of cardiac pulsations, cardiac activity has appeared. So this gives a signet ring appearance, but very soon, this will be hardly there for 4 or 5 days, you will get another ring of amnion. Okay? So please tell me the position of the embryo and the yolk sac in relation to the amnion and the chorion. Somebody in just one sentence. There is
Dr. Anybody would like to take that question?
Where is the embryo situated in the amnion? Where is the yolk sac situated? How are the amnion and the chorion connected to each other that ways? I think I'm
The
going.
amnion
Embryo will be in the
and the yolk
amniotic
sac.
cavity.
Yes, yes. See, you can see this diagram. See, the red arrow is the embryo. And surrounding the embryo, the ring is the amnion. But this is the yolk sac. Yolk sac is in the chorion. So chorionic cavity. So remember, embryo is always intraamniotic. Yolk sac is always extraamniotic and intrachorionic. Am I clear? Understood? So that is how you can differentiate the amnion from the chorion. This is another appearance. You can see the top diagram. I'll give you a pointer. So sorry. Can you see my pointer?
Yes, ma'am.
Yes,
Huh?
ma'am.
Yes, ma'am.
Yes,
Yeah,
ma'am.
it's visible.
Yeah. See, this I wanted to explain you. Over here, this is the amnion. Can you see? This ring is the amnion. So the yolk sac out here is extraamniotic. And it is intrachorionic. This is the chorion. Outer is the chorion. Inside is the amnion. So there is a space, there is space between amnion and chorion. Yolk sac is present in this space. But embryo is totally intraamniotic. So what happens at 14 weeks? The embryo grows, the amniotic cavity grows, and gradually this space reduces and this amnion fuses with the chorion and the yolk sac disappears. Got it? This is the whole thing. And yeah, so this embryo increases in size from dot to rice grain to kidney bean, and ultimately you can start measuring the CRM. Okay? How do I? How do I stop the pointer?
Hidden. Put it on hidden.
Hidden. Yeah, thank you. So coming to the next, now the embryo has grown and become a fetus. After, fetus you start calling at 9 to 10 weeks. All the organogenesis is complete and the amnion and the chorion have fused. So I hope till this time the scanning you are very comfortable in measuring the CRL and all. You start measuring the CRL and this yellow arrow is telling you how the amnion is going closer to the chorion before getting fused. So this is the order. Now I have summarized everything, and you will know now from tomorrow when you do your scan of a patient who has just missed her period, you'll know what signs to appear. So can you tell me, Manisha, what is the order of appearance of these signs in early pregnancy?
First, we will have the ring, gestation sac small, and then we'll have a fetal pool and yolk sac, and then the chorion.
Then the fetal pulse,
Observation of the
cardiac pulsations, and then you will have the amnion, right? So ultimately, this is the appearance you will get at around 6.5 to 7 weeks, right? So the take-home message is that any rounded or oval fluid collection in a woman with a positive pregnancy test most likely represents an intrauterine gestational sac. You have to confirm with all the definitive signs. So can now somebody tell me, how do you measure the gestational sac? Can you tell me the method of measuring the gestational sac? You are doing a gestational sac measurement. You have a TB probe and the pregnancy is approximately 6 weeks. Anybody can take this question.
Dr. Nidhi?
We can do the measurement in three, the longitudinal, the length, height, and width divided by 3.
Yeah, go on. What part of the sac you measure from chorion to chorion? Or you measure the anechoic area of the gestational sac?
Anechoic area, ma'am.
Yes, you have to exclude the chorion, remember. And you must have all measured the ovarian volume, no, in gynec scan?
Yeah.
It is always three-dimensional because volume is a three-dimensional unit. So it has to be an X, Y, Z axis, with the longest axis being the length. We always take the anechoic area because if we measure the outer one, we'll be measure the decidual reaction and then it will be wrong. I think most machines now have automatic calculators. You just put the measurements and they calculate the mean gestational sac diameter for you.
Yes, the only thing is I wanted to add, you have to rotate your probe 90 degree.
Absolutely.
To get like the ovarian volume measurement, you introduce your probe, you visualize the gestational sac, you take the 2 dimensions and then rotate your probe through 90 degree anti-clockwise and take the 3rd dimension. Okay. So this is how you measure. Coming to fetal anomaly detection in the first trimester, there are certain things, certain fetal anomalies, we may not have seen all of these anomalies in our practice, but there are certain anomalies which are always detectable, some which are potentially detectable, and some which are undetectable. So when we are sitting with our machine, whether in Ratlam or in, Jaora or in Tamil Nadu, we should know that this anomaly is there, never miss it. Okay. So this is also a table which tells you almost always you are likely to diagnose, likely, potentially, or unable to diagnose. So can somebody tell me the always detectable fetal anomalies at 11 to 13 weeks scan, which you should never, and Dr. Priya has told us about all these anomalies. She's shown us beautiful images also. And can you tell me what is each? Just little bit, what is each, definition.
Acrania and anencephaly.
Yeah. I'll be asking you questions on acrania and anencephaly also. This you should never miss. Anybody who is doing ultrasound for early pregnancy or obstetric scan should never miss acrania. Next.
Omphalocele gastroschisis and megacystis.
Okay. So I'll be of course taking questions on this. So these are the it's a list of 9. No, Anshu? The list is actually 9 anomalies which are always detectable, but definitely you should not miss acrania and alobar holoprosencephaly, which are related to the CNS, omphalocele gastroschisis, which are related to the abdomen, megacystis, which is related to the bladder, and body stalk anomaly, which is also known as limb body wall complex. So what happens in acrania and what happens in anencephaly? Can somebody just tell me what is actually acrania? You are seeing the image over here.
Ma'am, acrania is the absence of skull bone only.
Yeah.
And anencephaly is the absence of skull bone along with brain matter.
Right. So actually, it's a sequence. Can anybody tell me what is the
partial or
Okay, can somebody
it could be partial or complete absence of the cranium goes with acrania.
Partial or complete? I think when the cranium is absent, it's absent only. There is ossification of the skull bones of the fetus at 11 weeks. This does not happen. So the brain is free floating. It is acrania. So can somebody tell me the appearance of a normal fetal head? When you do an axial scan, what all structures do you see in a normal fetal head at, let's say, 10 weeks or 9 weeks? You're seeing the images here. You just have to say, tell me the structures.
We can see the falx cerebrum, ma'am, and we can see the choroid plexus, the lateral ventricle, and the border of the skull.
Yeah, and what is
we can see the thalamus?
Thalamus is also visible, yes. So what is the peculiarity of the choroid plexus at this stage, which will make,
They occupy the main, they occupy a lot of portion of the,
Exactly.
They look very big, yeah.
And what is it? What is the appearance called? It is called butterfly appearance.
Yeah.
The choroid plexus appear as butterfly. It is called the butterfly appearance because the gray matter of the brain is very less, very thin. So the choroid plexuses are spreading all over the ventricles, and the cranial bone ossification should be visible by 11 weeks. Now this is actually a sequence. One sec, I'll just plug my Mac. So this is acrania, exencephaly, anencephaly sequence. What happens is this begins with acrania. This is the most common anomaly affecting the CNS with an incidence of 1 in 1000 pregnancy. So first, there is in acrania, there is normal appearing exposed brain, just the absent cranium. Then it turns into exencephaly, that like an amorphous brain mass. The brain starts floating inside the fluid, the amniotic fluid. And then ultimately all the brain tissue is absorbed and it leads to anencephaly. And we saw the beautiful pictures that Dr. Priya showed us of frog eyes of anencephaly. So what is an encephalocele? How do you diagnose it? What appearance, what happens in encephalocele? Anybody can take this question?
Just a protrusion of cystic mass, cystic area.
Yeah, so here there is a small defect. Like somebody was saying, a partial acrania. So this is not like partial. There is a small defect in the fetal calvaria from where the brain matter protrudes out, and it is surrounded by a membrane. It is an encephalocele. And is it a lethal anomaly, or this pregnancy can be continued?
Lethal.
Aishu, can you tell us something about encephalocele? How do you manage a baby with an encephalocele? Suppose the encephalocele is seen at 11 weeks.
Then we usually do a follow-up, and again, it also depends on the chromosomal study. So we might require to do either a further evaluation with an amniocentesis or a CVS, and then decide what the management is. If it is a significant portion of the brain that has herniated out, then of course it is incompatible. If it is a small portion, then if the patient wants to continue, you might consider monitoring it. But again, depends on the patient.
Yeah, so first of all, you have to disclose the findings to the patient and scan the baby properly, fetus properly for any other soft markers, and then probably suggest the chromosomal test. If the patient is ready for invasive tests like amniocentesis, that will give you a lot of information. And ultimately, the decision is for the patient to take. Even if the patient wants to continue the pregnancy with a very abnormal baby, it is totally her choice. You just have to be advisor and basically be there. It is for the patient to decide. Can you tell us something about this scan? What scan is this? What all structures are you seeing? And suppose, yeah. Can you describe an NT-NB scan? Any of
Yeah, we can see a beautiful double sign for the nasal bone. Nucleus translucent can be easily seen. The depth can be measured easily.
Okay. Yes. So, so we are seeing 3 spots over here, out here. Okay. You can see within the circle, within the rectangle, you can see 2 parallel lines, not very parallel. They are sort of angled lines. What is the top line and what is the bottom line?
Top line is
Top line is the skin over the nose, and the bottom line is the nasal bone.
Exactly. And there is another line, there is another spot where the arrow is pointing, the top arrow.
This is the palate, the maxillary plate.
No, I'm not talking about this arrow. I'm talking about the top arrow, which is pointing near the nose. What is it?
Skin over the tip of the nose.
That is nasal tip.
Nasal tip.
Yeah. So you should know, one is the nasal skin, the other is the nasal bone, and third is the nasal tip. Here I must thank my teacher and my mentor, Dr. Kuldeep Singh. I mean, he has taught us so much of this anatomy that I tend to teach it, because you see all these on ultrasound with a good machine when you're doing it. And then the lower arrow, what is it? The arrow which is near the chin, what is it pointing to?
The palate, that is.
It's the
palate maxilla, ma'am.
And what is the central arrow in the middle of the head pointing to? This is pointing to the diencephalon or the midbrain. Okay. And below the diencephalon or the midbrain, I just wanted to tell you this, because you are reading the, you are getting the NT scans, and sometimes we don't know how to. Now I'm not getting my pointer only. Anyways, so there is below the diencephalon, there is one sonolucent area, that is brainstem. The second sonolucent area is the intracranial translucency, also known as the fourth ventricle. The third sonolucent area is the cisterna magna, which is bounded posteriorly by the occipital bone. And the fourth out here, where 1 is written, this is the nuchal translucency, right? So people who want to start measuring nuchal translucency, from tomorrow you have to start practicing it. And it is very easy to learn for a gynecologist or an obstetrician who is doing 15 scans per day. Trust me, if you're doing 15 obstetric scans per day, you can master doing the NT in 4 to 6 weeks. So this is what I was telling you. There are the sonolucent spaces at the back of the head. One is pointing to the brainstem, second to ICT, and third to cisterna magna. Okay, that is enough about NT scan. So please identify this lethal congenital anomaly. Give me the name. Come on, it was there in always.
Holoprosencephaly.
Yes. So this is the A-lobar holoprosencephaly, very lethal anomaly. And just now Priya madam told us the midline facial defects, the proboscis, this is associated, the midline facial defects are associated with A-lobar holoprosencephaly, and there is a single large midline ventricle. Nobody should miss this anomaly in the 11 to 13 week scan. Okay. So, what is physiological midgut herniation, and why does midgut? You keep saying this is physiological herniation. Then another patient you say it might be omphalocele. So, why does the gut of the fetus herniate, go outside, and come back? Can anybody tell me this? You can read also. There is no problem.
And there is a rotation of the gut happen embryologically. So
yeah, see, it's written very.
That's why it herniates out, get rotates, and then it comes in.
Yes, I think we all remember. I'm Roger. Yeah. So this gut has to go out first, then it has to rotate around the axis of superior mesentery artery. That leads to the typical position of the gut in the abdominal cavity. This herniation, the defect should not be more than 7 mm. And if this happens after a CRL of 44 mm, then you are worried. Then it is not physiological. Okay. So this is something physiological. Now tomorrow when you do scan, in your center and you see this a little bit of bulge over the umbilicus and it's around 9 to 10 weeks, you will not get hassled and you will not worry, because this might be physiological umbilical herniation. And see, the umbilical cord is at the tip of the mass. Can you see? It is arising from the tip of the mass. So physiological herniation is like this. It will disappear on its own by 12 weeks. Now, what is omphalocele and what is gastroschisis, and how do they differ from each other? I'll show you a very nice diagram. These are actually part of ventral anterior thoraco-abdominal wall defects. And Dr. Anshu will tell us how do they differ. First, the panelists can take the question if anybody is confident about it. I've given you a beautiful diagram. Just don't worry. Don't worry if you have to read and tell. See, I told you it's this panel. We are going to just talk to each other and try to become expert in first trimester anomaly scan. Okay? So we have to be just, regardless, you just read and tell me. How does gastroschisis and omphalocele differ from each other?
In the herniation sac will have the bowel loop as well, so it will be seen sitting on the cord insertion. But in gastroschisis, the herniation is parallel. So the cord will be seen over the left side and the bowel will be seen separately.
Which has got a better prognosis and which has got a bad prognosis?
Omphalocele has got a better prognosis as compared to gastroschisis.
Yeah, it is mostly of membrane. Yeah, please continue, Anshu.
There is a covering over the omphalocele as opposed to gastroschisis, where the intestines are directly exposed to the amniotic fluid. In this, there is a small covering usually present, and it has a better prognosis compared to gastroschisis.
Yes. Here the umbilical cord is at the tip of the mass in omphalocele and it is at the side. Usually the umbilical cord is situated towards the left and the herniation is towards the right usually, but it may be the other way around also. So this is all about, definitely these are also markers like Dr. Anshu told us. They may be associated with other biochemistry problems. You have to choose the type of test you're going to do. You're going to do invasive. Naturally, you might have to do invasive test. Invasive test, you have to choose between amniocentesis and chorion villus sampling depending upon the gestational age, and then counsel the patient. So these are another, see, this I wanted to show you. See, in gastroschisis, you can see abdominal loops outside. So there will be this irregular, shaggy sort of feather-like appearance. Not feather, but you can actually see the loops, right? And this is omphalocele. Omphalocele is like a smooth bulge. Upper one is omphalocele. You can see the membrane covering it. And the lower one is gastroschisis, where you can actually see the bowel loops just scattered within the amniotic fluid, right? Now, what is megacystis? And how do you measure the urinary bladder in a fetus? What is the importance of megacystis? And if none of you is confident, then Dr. Anshu can tell us about it. But you can take this question. I encourage you to just read and try to answer.
When the dimension of the bladder goes beyond 7 mm, then it is associated with some, it is a soft marker actually. So it could be associated with other anomalies. So one has to look for.
Anshu, can you add something?
It could be associated with essentially outflow tract abnormalities of the bladder, like a posterior urethral valve that is causing backflow and causing megacystis. And it is depending on how big it is. If it is small, that is, if it is 7 to around less than 15 mm, most of them resolve spontaneously. If it is more than 15 mm, that means there is an obstructed ooze. So if there is an outflow tract abnormalities along with megacystis, you will also have abnormalities of amniotic fluid, such as oligohydramnios, because essentially the fluid that is produced from the fetal urine is not getting produced. Most commonly, usually it is associated with the posterior urethral wall, which is again more common in male fetuses compared to female fetuses. But that is a detailed discussion. But it again depends on how big it is, and that will determine whether you will follow it up or whether it is a lethal abnormality and how soon are you seeing this abnormality. That is also a factor.
And Anshu, can you please explain us how to measure the fetal urinary bladder? See, everybody, please, this I'm talking about only first trimester anomaly scan, which we are going to start doing tomorrow. So all these fetuses are first trimester fetuses, and we should know how to measure what. Anshu, please, can you tell us?
Again, bladder is a three-dimensional structure. We measure it in the sagittal section in 2 planes, and then you measure it again in the coronal section. In fetuses, usually we measure it in 2 axes in the sagittal section.
Actually we don't need the coronal section here. The measurement of the urinary bladder for megacystis, the guidelines say keep the fetus in the sag section, and the bladder has to be measured from cephalic to caudal, longitudinal, single line, and that will give you the measurement. No need to measure the volume of the bladder over here. And your magic figure is 7 mm. But most of them do resolve, remember. So
sometimes you get the classic keyhole appearance if there is a
lower urinary tract obstruction. So no need to get tomorrow if you get a bladder of 10 mm, no need to panic, because if this fetus is euploid, 90% of these megacystis will resolve by the time fetus reaches 20 weeks of gestation. Now, can somebody tell me what is body stalk anomaly? Again, this is one anomaly you should never miss. Okay, what is body stalk anomaly? It is also called limb body wall complex. Anshu, you can answer this question.
Okay, the mass-like structure is adherent to the wall.
So this is again, see, you might be finding these questions a little difficult, but what I want to impress upon you, when I asked you what is your ambition with ultrasound as your career, all of you said that we want to start doing anomaly scan, right? So when you want to start doing anomaly scan, there are certain things you should learn to recognize, and the more the volume of your patient, the more cases like this you will see. So body stalk anomaly is basically the fetus is amorphous, it is deformed, the spine is deformed, it is stuck on one side, it is will be having associated chromosomal anomalies also, and it is totally incompatible with life. And here you can see along with the amorphous fetus, there is a band-like structure, which is stretching. This is the amniotic band. Okay. So next we come to potentially detectable fetal anomalies. There are some anomalies which are, you might detect and you might not detect. Here, you might have to refer the patient if you're not an expert. So, Anshu, can you tell us about this?
So whenever we're doing an anomaly in early or a fetal assessment, all extremities have to be examined and measured. Sometimes you have to measure both the humerus, both the femur, both the tibia, along with seeing the hand and feet and all digits. As Preeti ma'am said, measure or see all 5 digits. So sometimes you might have like a small an absent hand, or it depends. It could be simply just the palm, or an absent a radius or ulna, or even sometimes up to an absent humerus. This can be difficult to determine because of the movement of the fetus that can be there. Second, what we saw a very nice diagram of a congenital diaphragmatic hernia, in which the diaphragm is completely or partially absent. This could be either due to agenesis or incomplete fusion. In that case, the heart and the stomach will be in the same preference. Then short and long limbs, the skeletal dysplasia, what we call as, also I think that's what it. And
Skeletal dysplasia, you should be able to diagnose, but sometimes you're not able to diagnose, because the fetus is also small, the limbs are also small. So that is the time it is called potentially. See, here in this fetus, it's a 3D. You can see one lower limb is totally normal size, but the other lower limb is a very small limb. So if you see a fetus like this, definitely take a, either report yourself or take a second opinion. Facial clefts also might be missed, because this is another thing, like patient will not leave you. So though it is potentially detectable, but wherever you see a spur, what is a typical thing in a facial cleft? You will see a protruding spur like in the upper lip, in the area of the upper lip below the nose. This is typical feature of facial cleft. Here, if you find anything which is out, away from normal in a fetal case, always refer or take a second opinion. Now, there are certain anomalies which are undetectable at 11 to 13 week scan. So, if this patient comes to you or takes you to court that you have not detected this, you should always get it signed or have a consent that these are the anomalies which cannot be detected in the first trimester. Anshu, can you tell us why?
Uh, 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 the corpus callosum may be very small. Second, microcephaly, what we say is the head dimension that is smaller than the normal. This can again be associated with some infections such as Zika virus. However, when the cranium is very small, it might be difficult for you to determine this. Again, airway obstruction, these are very tiny structures, which is very difficult to see on first trimester ultrasound. Sometimes, as we said, bowel obstruction, if you're doing a scan a little early at 12 weeks, or and the herniation has not protruded back, then you might miss all of these anomalies. So there is a lot of that. Sometimes because of the patient's position, the fetal visualization is difficult. The baby is very small. Even maternal obesity can have cause difficulty in visualizing all of these structures in very detail. So it is possible to miss these, especially if you are starting out.
Yes. So remember, corpus callosum develops after 14 to 16 weeks. When the development of the corpus callosum is happening after the first trimester, you cannot comment on it. Similarly, congenital pulmonary airway malformation is also very difficult to diagnose in the first trimester, and all GI problems. So these are the things, wherever you're doing an anomaly scan, you should have these ISUOC guidelines. So Dr. Manisha, can you tell us what all things we should always observe in a fetus while doing 11 to 13 week scan? This is a list, and I've told you all of them.
Yeah, actually, we should do a systematic observation of the fetus from top to bottom. So from the head, we'll look what are the things which are present, like calcification of the bone, midline parts, choroid plexus filled ventricles should be seen. Then the neck should have a normal appearance. Then NT measurement should be done. Then we should come to the face, and we should be able to see the both eyes with the lens inside the nasal bone, the superficial skin over it, and normal profile with mandible and intact lip should be seen. Then after this, we should move on to the spine, and we should see in the both longitudinal and transverse sections
which should to show the vertebra and the intact skin overlying.
It's very
And to detect
important, like Dr.
Yeah.
Priya, one sec, Manisha, Dr. Priya also told us, always have a pocket of amniotic fluid between the spine and the uterine wall, the myometrium, so that you can see the skin over the spine. That is very important if you want to rule out, occulta or open spina bifida. But you'll see a defect in the skin, which is very clearly seen. Please continue, Manisha.
Yeah, then we should move on to the chest, and you should the both lung symmetrical lung field should be visible, and there should be no collection or any abnormal masses in the cavity. Then we should be able to see the four-chamber view of the heart. The regular heart activity should be seen. Then we should bring down the probe and try to focus the stomach and the transverse section with the left upper quadrant, the stomach and the rib and all the porta should be seen in a single plane. Then we should move on to the bladder and measure the diameter of as Madam said, longitudinal dimension of the bladder, and both kidneys should be seen on the either side of the vertebra. Then we should move on to see the cord insertion and any mass or any abnormal herniation of the bowel in the cord insertion to rule out any abnormality. Then the four limbs must be visible with three segments of the limbs. Each limb should be visible. And a normal orientation of the hand and feet should be seen. And then along with that, we should see the comment on the placenta, its size and texture, and the cord, whether three vessel cord is there or no.
Now,
So
this
should
is interesting. Yeah, thank you. Thank you, Dr. Manisha. Remember, placenta, they have mentioned size and texture, but not location. I have a very beautiful slide of that also. Never mention on location of placenta in the first trimester scan. So how do you measure the situs? Can anybody tell me? Just now we heard Priya ma'am's lecture. How are we determining the situs by these two images? Can anybody tell me from the panelists?
The stomach is located on the left side, ma'am, and the heart is also located on the left side.
Yes.
So
Yeah.
depending upon that, yeah.
So this is normal situs. And what
Yeah.
is situs inversus? Situs inversus will be?
Heart is on the right side.
Axis deviates to the other side.
Yeah, both the orientation will be opposite. Okay. And this is another image where they are showing us the image of the stomach. And in the long scan, you can again see stomach below the diaphragm, and you are seeing the heart above the diaphragm. The whitish line in the right side diagram going transversely is the diaphragm over there. Okay, kidneys are a little difficult to visualize. You start trying to visualize the kidneys from tomorrow. You might not be able to see the kidneys. In that case, you can switch on your Doppler for a short while and you can see the renal vessels going to the hilum of the kidney, which will tell you the position of the kidney. Okay. You should always see the continuity of the abdominal wall and you should see the cord insertion. On the left side, you can see the cord inserting into the abdominal wall. And what is the importance of the right diagram? Can anybody tell me? What am I trying to see in the right side image? This is the urinary bladder.
Three vessel cord.
Yes. Please tell me, how will this image tell me that the vessel is 3 cord and why? It is all a mixture of embryology, anatomy, ultrasound.
Because there are two red lines and one blue.
Yes.
Yeah.
Can anybody tell me what are the vessels which are seen on both sides of the urinary bladder? These are the umbilical arteries. The umbilical arteries, and there is one umbilical vein. Okay.
Yeah.
The right and the left umbilical artery and the left umbilical vein form the umbilical cord vessels, right? So when on both sides of the urinary bladder you are seeing one vessel each, both of them are two umbilical arteries. So it is a 3 vessel cord. Okay. Yeah. This is a simple way. Just go to urinary bladder, switch on your Doppler. If you see both the vessels on both sides of the umbilical urinary bladder, it is a 3 vessel cord. So again, the thoracic lung feeds have to be symmetrical. The heart has to occupy 1/3 of the thoracic cavity, and you can very beautifully make out the cardiac axis. You can make out the fourth chamber of the heart. You just have to zoom the image. Always use the right zoom. Don't use the read zoom. So what is the read zoom and what is the right zoom? Anybody? Anybody who is doing ultrasound and knows how to use the zoom? Anshu, can you tell me?
So we have what I call it, you can equate it with a similar camera. There is a one zoom button that rotates, that does a full screen zoom. And what happens in that, if you're doing a light image, like a phone camera, if you zoom the image, your pixels get separated and then the image becomes less clear. As
Yes.
compared to a focal zoom that we call as a box zoom, that creates a box around the image. So whenever you're doing a live scan, always use a box zoom and focus that area that you want to see during a live scan. If you want to focus it later during when you're reviewing the image, then use the global zoom, that the thing that we turn on the machine. Again, you might also need to adjust the depth of the image and the focus. The focus is the arrow that you see around at the side, and the depth will increase the area and without affecting too much the pixel quality. So you always use a box zoom, not a
Yes, yes. So Anshu, that was a beautiful answer. Thank you. And anybody who wants to know about, these techniques and zooming, please attend the lectures by Dr. Suresh from Mediscan Chennai. He does excellent, teaching programs, basics, absolutely basics. So there is something called read zoom and there's something called write zoom. Read zoom is basically turning the button, the whole image, just the pixels also go down and the image zooms up. But right zoom is the box zoom, which Anshu is saying, which is the right way to do. So here, spine always have some little bit of fluid if you want to see all the spines. These are the extremities. It is not necessary to count the digits, remember. And if you miss a polydactyly, it is not a crime. So what Dr. Priya told us was the second trimester anomaly scan. What I have conducted the panel with you is the first trimester anomaly scan, but both of them cannot replace each other. Both of them have got predictive values of their own, and it is only when you do the first trimester anomaly scan well, along with the second trimester anomaly scan, then you can get a good prenatal detection rate of more than 90% in your pregnancies. Who can tell us the benefits of doing? See, you can see that huge megacystis over here. Can you see all of you? So, what are the benefits of doing an early anatomic scan? Anybody? Suppose
With the advancement in the machines and see more, and there's inverted pyramid now. Now, whether as the earlier the pyramid was like first trimester we had minimal mental visits and
We
more
can
in
know.
the second, third trimester, but now the focus has come on the first trimester, where we try to
please,
predict and
somebody mute
diagnose.
yourself. Except the speaker, please mute yourself. Yeah. Yeah.
So with the inverted pyramid approach now the focus is towards the first trimester where we can diagnose and predict as much as of the pregnancy outcome as possible. So that is why the first trimester anomaly scan is become gaining more and more importance these days, so that we avoid the early later gestation terminations, which are definitely have a worse prognosis than the first trimester terminations. There's lesser emotional attachment of the parents with the fetus, and also definitely the cost of the maternal care also reduces, is better. So first trimester scan is definitely better. If we can diagnose as much in the first trimester, that is definitely better than diagnosing late in second trimester.
So I want to tell you a real life. I don't know whether she is attending the webinar or not, but I have a colleague in Bhopal and she started learning ultrasound with me or after me. And I think she has a basic machine. She recently diagnosed a hypoplastic left heart syndrome from first trimester anatomic scan. Can you imagine? She just could not see the four symmetrical chambers of the heart. Very dedicated gynecologist, very hardworking, and she could not see the left chambers very well. She came to a diagnosis of HLHS, that is hypoplastic left heart syndrome. We asked our teacher, our mentor. Sir replied, and it was indeed a case of that, and the pregnancy had to be she must have terminated. So, why is placental location in relation to cervix not predictive in first trimester scan? Anybody, all our obstetricians, everybody can take this question. This is a 13-week scan, and you can see the placenta is completely covering the internal os. So, will it turn into previa? Yes or no?
There is placental migration, so this might not be predictive of placental location.
So is there anybody who says this will definitely be central placenta previa?
Yes, ma'am. It's so like in
Can
the
you see
center.
can you see the internal os? You can see, na?
Yeah, ma'am. The whole
Covering the os, yes.
whole cervical line is seen, ma'am.
So I will now show you the scan at 18 weeks. See, at 18 weeks, she is the same patient. At 18 weeks, the lower margin of placenta has completely moved away from internal os. Okay, it has become an anterior placenta, safe distance away from internal os, and this is the same patient. So remember, mention only the morphology of the placenta, the texture of the placenta, but never comment on the location or position so early. Don't waste your time, and don't panic the patient unnecessarily. Now we should know about Alara principle. Everybody, all of you will notice tomorrow on your machine what is the TI. I keep my TI less than 1, but after preparing this lecture, I think I will start keeping my TI less than 0.7. Anshu, how much do you keep it? Your thermal index?
Usually less than 0.5, 0.7 or possibly 0.5, but mostly 0.7.
Yeah. So I will reduce it tomorrow because I used to keep it nicely 0.9, less than 1.8. But tomorrow I will reduce it further because it is always better to monitor the energy output. So
Also,
Alara,
first time is there use the M mode, not the B mode to do it.
Yes. So this is another slide which is saying like this only. I have seen some people just putting the spectral Doppler for fetal cardiac activity. That is so inhuman. I mean, I will not call it cruel, but that is not the way you should do, treat the fetus like this. And how should you measure the fetal heart in first trimester? Dr. Radha Lakshmi, how do you measure the fetal heart in first trimester?
Just by M mode we can measure.
Yes, M mode is made for that only. Okay, why are you unnecessarily putting Doppler? So, and always limit the time of keeping the probe over the fetus also, especially if you're using Doppler, because these Doppler waves are going to have some sort of thermal sort of damage or whatever tissues and fetal brain, fetal eyes, what influence they have on the fetus, we don't know.
So mainly Dopplers, what the thermal generation does is it causes cavitation, and this can lead to then neurogenic abnormalities. Although we say that ultrasound is comparatively safe and people usually avoid it is safe, but nowadays increasingly patients are coming up ki, should we get a TVS done, how much exposure it will be. So limit the time to as short as possible. So that will only come if we do more and more scans, so that time per scan will reduce and then our thermal index will reduce.
Definitely. So the only way where we can do this, Anshu, is by knowing the importance of TVS. Where you have good TVS and it's a fatty patient or thick habitus, don't waste your time on transabdominal. Just put the probe once and then go to TVS. Educate and train. There is never a day when you can't learn anything. In fact, preparing these slides only for you all, I have learned so much. Time your ultrasound well. Always use your knowledge of easily recognizable soft markers. Know your genetics well. Know the chromosomal tests well. Keep reading and follow protocols like the ISUOC guidelines. Always have guidelines ready because these guidelines have been made by very, very experienced people. This is the difference between, transvaginal and transabdominal scan. All of you know about it. And this is how your detection rate goes up. Using both TA and TV, your detection rate is 62%. Only TV is 34%. This is actually TA TV is controversial, but definitely you should have an optimum use of both the. This is another very interesting case. Here, the patient was very fatty, and on transabdominal scan, we found an NT of 2.2, and that's it. The image was very, vague at 13 weeks. But on TVS, this patient showed an open spina bifida. Can you see? So this is how the transabdominal image and the transvaginal image can differ from each other. So you have to make optimum use of the modality. And ultimately, we want gynecologists, whether they are in Ratlam or they are in Jaora or they are in Katni or they are in Bhopal, we should want them to be confident doing simple obstetric scans. And one thing I would like to tell you is that remember, you said you are from a small place. It's not a small place. You don't know how blessed you are because that small city is giving you volumes of work. In city like Bhopal and Indore, all the patients are divided. They will go to 200 nursing homes. So we don't get that much volume, which in a place like Ratlam or Katni you can get. And I'm so sorry if my questions were a little out of the way, but I just wanted to encourage all of you to start doing anomaly scan yourself and seeking your humble blessings for my candidature as chairperson Foxy Perinatology Committee in Foxy elections of 2024 and managing committee member of ISAR. Thank you so much. And I'm stopping
Very
sharing
nice,
now. Thank you.
Yes,
This
we are
is
coming to
how 3D can help you. This is a normal fetus on 3D and this is the abnormal fetus on 3D. So we thank you for a great panel and you should never come to the position where you have to, sacrifice your findings or basically be in doubt and never hesitate to take help from your colleagues, from your seniors, from your juniors. Always be ready to call, to take an opinion, to learn. It's never too late. Thank you so much.
Thank you, madam. Thank you, madam, for the wonderful session. We
Wonderful.
learned a lot.
Thank you to all the panelists.
Yeah, and
Thank you, Monica ma'am, for providing all of us such a good platform.
And
And
we can
special
keep
thanks to Bhopal Obstetrics and Gynec Society.
And please, I'll just take a screenshot of all of us. And remember, we'll keep this group open. Whoever takes a good image from tomorrow in OPD, please post it in the group. And we can keep our discussion open. Maybe Dr. Aarti will find a, omphalocele tomorrow. And Dr. Radha will find a neural tube defect tomorrow. And Shruti will find gastroschisis. So, I mean, let us keep. See, I really tell you, in big cities, our volume of cases is less. The amount of cases you get in other periphery is tremendous. So you can give us the, findings and everything, and everybody can learn. Thank you so much.
Thank you so much, ma'am. It was great.
It was really very, very nice.
No, I was
basic and very useful.
No, I was a little upset because nobody was, answering. So I thought maybe questions are too tough,
Ma'am, I had to leave in between. I had a delivery patient. I'm so sorry.
No, it's okay. We should all, just try
Ma'am,
to.
I had to leave in between because of some OPD patients.
I see.
It was really difficult, but it was very nice presentation, ma'am.
There was a time I also used to do simple biometry. I used to do biometry, cardiac activity, placenta, cervical length, and finish. I used to call my friend, my classmate, my batchmate, and she used to do my anomalies and Doppler and everything. But COVID and all, I changed everything. I decided that there should be nothing in fetal medicine which I don't know. I'm still doing fetal medicine, but wherever I need, I take help from my colleagues and my, other people in Bhopal. So thank you, Intas. Thank you, Dr. Vivek Sharma. You've done an excellent job, and I must compliment you. And I thank Intas for giving us this platform. I thank Foxy for giving us this platform. I thank Bela ma'am for giving us this huge opportunity to listen to such beautiful speakers today. Thank you so much.
Thank you, ma'am.
Shruti bolo.
एक केस डिस्कस करना था now that I have you here.
बता.
एक मेरे so called ड्यूटी डॉक्टर हैं तो मेरे VIP पेशेंट समझ लो. तो first in the last trimester we generally don't do we do Doppler in all the patients?
Yeah,
We
do
patients and rural clientele है. Do we do Doppler in all patients? I don't
Yes,
think
ma'am. I practice in Katni and I do Doppler for all of my patients.
We do.
Whosoever comes after 32 weeks,
least one
and
umbilical
even
artery.
if it is the first scan for that patient.
See, first, Shruti, we have seen pre-eclampsia pregnancy prediction. Dr. Smita Dengle has told you, you have to do a Doppler right from, first trimester, second trimester.
This patient was a completely booked patient. इसका NTM भी हुआ, anomaly हुआ, everything was going fine. टोटली सिम्टमलेस मस्त चली। 36 वीक्स में नॉर्मली ग्रोथ स्कैन और रूटीन अपन देख के आगे डिलीवरी प्लान करने लग जाते हैं, isn't it? So 36 weeks में, because she was my so-called VIP patient, I just randomly asked her कि तू डॉपलर करा के आ और रेडियोलॉजिस्ट के पास भेजा। अभी तक मैम उसका पूरा पैरामीटर्स भी सब मैच कर रहे थे। आज वो मेरे को स्कैन लेके आई, 36 weeks by dates, 34 weeks by sonography. Only the femur length is matching with 36 weeks. Rest of the parameters are 34 weeks. And the terms that he has written, I'll read it out to you. Persistent, just give me just half a second.
Ma'am, I just want to point one point. Recently, we had a workshop from Dr. Chinmay Ratha Madam at Katni Obstetric Society. She pointed out this point that late onset IUGR are common, and it is actually common and very less detected.
Yeah, it is common. So let ma'am read the report.
Yeah,
Persistent early diastolic notching on uterine artery Doppler. Hypermature placenta, cord around fetal neck.
Cord around neck is not important.
What about the umbilical and the MCA Dopplers? Has he mentioned anything about the CPR?
No, he did not. No, he did not. And now I was in big soup what to do.
So then that means that incomplete Dopplers have been, without commenting on the umbilical, the MCA, and also the amniotic fluid. There will have some sort of amniotic fluid abnormality as well.
Mean uterine artery PI is 197th percentile pathological. This has been written. And normal forward flow is noted on ductus venosus Doppler. These are the sentences written in the report.
The report is not a very...
report is not complete. Yeah.
And you should have the CPR. You should have the CPR. You should have Anshu said amniotic fluid volume.
So, Didi, in सब conditions में I get very perturbed now what to do. अब मैं इनको फिर स्मिता के पास भेजती हूँ.
Yeah, you can refer to Bhopal once. You can refer to
like another patient. अब भी उसको डिलीवर करके आई, इसलिए इतना बढ़िया पैनल बीच में छोड़ के जाना पड़ा मैं. वो अच्छे से डिलीवर हुई, 2.6 kg फीमेल में भी, रोबस्ट में भी, मस्त बच्ची है वो, डिलीवर हुई. बट यहाँ सोनोलॉजिस्ट ने उसमें IUGR स्टार्ट हो रहा है, इंट्रायूट्राइन ग्रोथ रिस्ट्रिक्शन, ओलिगोएडेमियास, ये सब लिख के दिया. फिर स्मिता के पास PI गड़बड़ पैथोलॉजिकल लिख के दिया, तो मैं स्मिता के पास भेजी. So she did it on her own, and then she reported that it's all okay. Or corrected EDD is this. Otherwise, uska by date CDD was 19th of December.
So you have to stop referring to Narmada.
To radiology. That is the main thing.
तो मैं दीदी यही आपको बता रही हूँ. उसके बाद मैंने खुश होके उसको इंड्यूस किया और सुंदर बच्चा भी अच्छा, पेशेंट हैप्पी. पर ये सब देख के, and this cord round neck is getting on my head. Please, इसका solution
It is
बताओ.
not significant at all, unless there are 3 or more loops that are very tight or something. Even 2 loops deliver.
This is what we know, ना. पर जो पेशेंट आते हैं वो पढ़ के आते हैं.
That is true.
तो वो बोलते हैं कि गारंटी है कुछ नहीं होगा, ट्रायल में कुछ नहीं होगा. अरे जरा भी बेबी को जरा भी ग्रोनिंग हुआ, how will I explain? वो बोलेंगे कॉर्डर नेक का तुमने क्यों?
Basically, you have to stop with the due respect. You have to stop referring to the radiologist whose report is not matching with your patient's findings, and have a radiologist who is well versed in all the guidelines and everything, like Smita, who knows everything. Like basically that your radiologist should be up to date, well read. So many things.
And the third trimester Doppler is absolutely incomplete without an umbilical MCA.
Should I ask him not to report?
नहीं, आप या तो उनको ट्रेनिंग पे भेज दो.
या उनको ये बोलो,
मोनिका मैम. नहीं, I'm not a trainer.
Shall I ask him कि भैया रिपोर्ट मत करो?
नहीं, you change your radiologist ना. See, you change your radiologist. उसमें क्या
You cannot
start visiting Narmadapuram once in a week.
ऐसा होता है क्या कि अगर लूज लूप है तो उसको रिपोर्ट नहीं करना चाहिए?
नहीं, you should not report.
है ना
If
मैम?
it is a loose loop, you do not remove.
Like you said,
And
nuclear
how
cord.
many times, all of you would answer me, has there been a loop of cord written in ultrasound and you have not found a loop of cord when you delivered the patient?
So many times we have incidentally
So-
found a loop and sometimes तो tight भी आता है. But patient deliver हो जाती है फिर दिखता है अच्छा cord था ऐसा.
The importance of nuchal cord, you can read, you can, read some good article on it. Shruti, all your conceptions will, concepts will become clear. And it is definitely not.
क्या होता है the inadvertent cesarean फिर बढ़ता है. Patient मेरे को बोलता है तुम गारंटी लो. मैंने कहा भाई गारंटी में नहीं ले सकती. तो ये कॉर्डरोम नेक देख के मेरी हालत खराब हो जाती है. मैं इसलिए आप लोगों से पूछती हूँ हाउ डू यू मैनेज
I think Anshu, we can keep a talk on cord around neck.
We can.
Ma'am,
Basically,
yes.
in report
Please do that. Didi, I will ask all our radiologists to mandatorily attend that.
Yes.
And
yes.
please.
Ma'am, is there any one book which you would suggest for us to read?
Neha, I have stopped reading books. Today only I
Basically, you have to do articles.
I just download all the articles, the latest guidelines. I download on my Mac, and I have got now one Mac is in my chamber, one Mac is in my bedroom, and my phone I have upgraded to 1 TB. So it's basically I'm all the time online. So I mean, I just like none of my panels I take from SlideShare. All the panels I prepare in 48 hours or 36 hours.
Okay, that's great, ma'am.
And also,
That's great.
yeah, I read Dr. Sonal Pancham's book, especially on Dopplers and 3D. Her books are very good. She doesn't do that much obstetrics now, but if you want to do Dopplers and all, her books are very good. And they have all published with Dr. Nagori a lot of articles also on that. And they have done studies. So that is a good one that you can read. Along with the Istiog, as ma'am said, the Istiog articles are very good. And a lot of the panels.
They're free of cost. And you know what? If you get time, you all of us go for vacations. So if you get time, just attend a good training program.
So I ask
A
you.
training
Have
program.
any suggestions for the training program?
My mentors are Suresh sir and Kuldeep Singh sir. My ultrasound teachers are Dr. Kuldeep Singh from Delhi and Dr. Suresh from Mediscan Chennai.
दीदी आप लास्ट सेमेस्टर के डॉपलर्स का भोपाल में रखो वर्कशॉप हैंड्स ऑन हमारा हाथ पकड़
And
के
for the training program, I would
Just
like to tell
now,
everybody.
Shruti, we
the
just
Foxy
kept it 1 week back. 1 week
Yeah,
back we had it in Chirayu. Huge.
Also for the
Next
training
time if it
program,
is there,
I would
please
like to
inform us.
say
हम भी आ जाएंगे
that
रतलाम से.
the Foxy
days
has
workshop
a
किया था.
traveling fellowship.
already
They
have more than
do.
150 participants.
Actually, when to deliver this question is answered so much by these Doppler tracings and all. They tell us so much. पर उसको हमको hands on आप सिखा दो तो हम decision ले लेंगे.
Also, I would say there is a Foxy traveling fellowship. So in that, all of us can, I did that. So the Foxy pays for you to go for 15 days for ultrasound, infertility,
You
endoscopy.
have to qualify for that, no, Anshu? You have to
Yeah,
qualify.
you have to qualify. So you can apply easily on online for Foxy because actually not a lot of people apply for it.
मैं तो कह रही हूँ
you
उसको
can,
ना उससे अच्छा you pay for the course and go for the course, na?
yeah, you can do it also.
You take dates. You go to train at Anshu's center. You go to train with Preeti Tomar. You go
with
to
Monica ma'am.
नहीं. See, I am learning ultrasound. I
But
do
you are
a
a
lot of
great teacher,
ultrasound.
madam. You should admit.
Yes,
You are a
but
great teacher. You know how to teach.
Ma'am, can I ask a case? Actually, I want to discuss a case.
Yes, please.
Last year, actually, I did a section on a baby. It was an elective section. There was some Murat delivery. So a healthy child was delivered, instant cry, nothing went wrong. And the child started having breath holding spells from the age of 5 months. And then it was a male boy. He was shown at with some pediatrician in Indore, and breath holding spells was diagnosed and nothing was wrong. Then the child turned 1 in October, and then he had a seizure fits. Then an MRI was done, and frozen cephalic cyst was diagnosed. So
What?
the frozen cephalic cyst.
Frozen cephalic.
Frozen cephalic.
Yes.
What is that?
So that was my question basically. And then they went to some pediatric neonatologist, and she said ki it should have been diagnosed antenatally in the scans. So the scans were done by a radiologist, and no cyst was mentioned there. So it's a frozen cephalic cyst is a cyst when there's a loss of
Porencephalic. It's not prosen. It's porencephalic.
Porencephalic, yes. Yeah, that was
Porencephalic. Porencephalic cysts are uncommon congenital finding.
Yeah, porencephalic, sorry. It was like there it should have been diagnosed, picked up antenatal.
Porencephalic cyst तो बड़ी cyst होती
But none of the scans were showing it. I went through the images again. So and during delivery there was immediate cry, pediatrician was there. The mother also vouches कि हाँ मेरे को बच्चा दिखा दिया था, वो तो फौरन रोया था.
You know what, Aditi, इसमें तो लिखा हुआ है कि porencephalic cyst में there is cystic degeneration and encephalomalacia. The brain tissue only degenerates.
Later on, na, matlab it.
So that hypoxia is causing the breath holding spell and everything.
So it is like if it has been missed, I don't know, but if it is not there, maybe the cause of seizures is not that cyst.
Yeah, I saw the images with they brought the.
If the patient is going to court or the patient is causing litigation problems, then what you can do is preserve these images very carefully.
No, I did not do the scans. The scans were not done by me.
Okay.
The patient is not going to court. अभी तक तो.
ठीक है.
But still keep a record of all the files
They were
and all
told
the
by the
counseling.
doctor कि it should have been. Actually, it is like the doctor without seeing the images said कि it should have been picked up. So I saw.
But there are so many things. First trimester scan कहाँ हुआ? Second trimester whether
all were done with a good radiologist in Ratlam, and the color Doppler scan was also done 9th month. उसमें भी there was MCA Doppler was done, and the text was mentioning कि middle cerebral artery में कुछ problem होता है तो जाके develop होती हैं. So MCA Doppler was done and it was normal. So the cyst should have been picked up, and it would have been there.
See, there are multiple causes of epileptic seizures, which might not be related to antenatal causes. They might be related, they might be postnatal in development. So this is totally not relevant that the cyst should have been detected. If the images are there with the radiologist or in radiologist machine.
And the brain development, and you'd also need to compare the brain development now. Like you must have had a cranial USG or something done for the baby
I
as
was
well.
done. Na, now it was.
Aditi,
So
I don't
rest
think you
of the
need to bother. You don't need to bother. You just tell your radiologist to keep the images in the system. If the patient at all troubles you later with litigation or anything, the radiologist has to produce the images and give the literature. That these are the conditions which can be diagnosed. These are beyond the scope of a radiologist.
Honey, I saw the
also
images
always
online.
everybody has a disclaimer that not all anomalies can be detected on ultrasound. So that is very important that you get that they have and keep that record
have
with
this
them.
disclaimer, but another senior neonatologist is saying it should have been picked up.
See, that is now a problem in the city. There's a problem in the city. If one person is speaking ill of another person, then you basically have to. You are from Ratlam?
Javra.
Javra, so all the gynecologists, radiologists have to sit together with a cup of tea or dinner and discuss कि हमें एक दूसरे के बारे में नहीं बात करनी.
This thing is not happening here. It was happening in Indore, basically. So, but I saw the scans and none of the scans is showing the cyst. And I went online also to see how the cyst should look.
Dr. Aditi, the cause of seizures might be something else. It may be metabolic.
This might not be the cause of the seizures. It is very hard to determine.
Yeah, so the radiologist basically should not confuse the patient by saying कि वो detect होना चाहिए था. Basically, that radiologist should have kept his or her mouth shut.
Neonatologist, yeah.
Yes. This is not done. But there is a group of fraternity who does this, and that is the reason doctors are soft all for everyone, because we are not supporting each other. We are not supporting our fraternity.
That is a reason for sectioning a cord around neck also, because if you don't do it and something goes wrong, somebody else will say it should have been.
Yeah, that's true.
Yeah. So first, always like up to Hippocratic oath ये है कि first keep yourself safe, and then keep patients safe, then keep your brotherhood and sisterhood safe. Okay. So let us now.
Thank you, Monica.
Bye-bye.
Thank you very much. And all the best for your candidature, and congrats in advance. You will rock, and we will rock along with you.
Thank you. And whoever is the president and secretary of societies, Shruti and Aditi, please vote for me in the chairperson, Foxy chairperson. Of course, ISAR election is a different ball game, But for chairperson election, I will be needing your support, kind support always. Thank you.
100.
Okay. Thank you, ma'am.
Thank
Bye
you.
bye.
Thank you, Anshu. You did a great job. Bye, Manisha. Bye, Purnima. Thank you.
Thank you, ma'am.
Thank you, all the
Bye,
panelists.
ma'am.
And sorry if I had tough questions. Next time I'll make a very easy panel.
No, it was very genuine panel and genuine questions. These are things we all should know.
Yeah. But now after 1 year, I would like to meet all of you again in another panel कि कितने cases आपने देखे, कितना काम किया.
Yes.
है ना? Okay. Bye. 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 Good night. Thank you, Dr. Vivek. Thank you, Inka.
Bye. Thank
Good
you
night,
all. Thank
everyone.
you.
Bye.
Bye.
Bye.